Hi, dear colleagues. This is Şengül Özdek from Ankara, and we would like to welcome you to the EVRS webinar. And you know, European Vitreoretinal Society is an open-minded society which stimulates everybody to share their experiences and observations. And our philosophy is we can always learn something new from each other, irrespective of the experience or age. ROP, on the other hand, is a real public health problem, especially in developing countries, leading to a preventable but untreatable blindness. And now we have a great faculty today. They are all very highly qualified, world well-known ROP specialists from all over the world. And I would like to thank them all in advance for accepting to talk in this course. And I'm sure the course will be very useful for the colleagues dealing with premature babies. Today, we will share our experience on such babies on the journey to prevent blindness. First of all, I would like to introduce you Dr. Giampaolo Gini, who is the president of EVRS, and he is together with us, and he wants to give his messages from EVRS. Giampaolo?
Thank you, Şengül. As you said, hello and welcome to...
Hi, Giampaolo.
Hello, can you hear me? Şengül, can
Yes.
you hear me? Yes,
I can hear you.
Right, thank you. Well, hello to everyone and a welcome to today's webinar. This is a part of a number of webinars which have been organized by the European Vitreoretinal Society. Some of these have taken place already. Some will take place in the months to come. Like many other societies, EVRS had to forego its annual meeting because of the pandemic. So we thought that by organizing these webinars, we would continue to play our role in continuing medical education. Now, as Şengül just said, EVRS is a society which is now 20 years old, and it is an established reality in the scientific world and among other scientific societies. Throughout these years, EVRS has remained faithful to its original philosophy and commitment of sharing knowledge in a peer-to-peer fashion. So learning from each other with no bias as to experience and to age of the members. We can all learn from each other. And this society has now been a reference point for many, many surgeons, and I am very proud of this. The name is a bit misleading because it is the European Vitreoretinal Society, but from its European origins, it has now spread to every corner of the world and is now represented in over 90 countries. As president of this society, I am privileged, along with the board, to welcome you all, welcome the audience to today's webinar, and to thank Professor Şengül Özdek, the distinguished panelists, for the tremendous amount of work that has gone into organizing such a complex meeting. And we are really looking forward to the contributions you will be giving us today. Thank you very much. Welcome. And I think we can give the word back to Şengül, and you can take over and we can commence this webinar. Thank you.
Thank you, Giampaolo. Now we will start our sessions, and the first one will be given by Graham Quinn. He will talk about international classification of ROP updated. But I just want to give a short introduction about him. He is working in the Children's Hospital of Philadelphia in USA. Actually, he doesn't need an introduction. He is the principal investigator for most of the important randomized controlled studies in ROP studies, like CRY-ROP, ET-ROP, LIGHT-ROP, G-ROP, E-ROP, every ROP. And he has more than 200 publications. Almost all of them are on ROP. And he was the outstanding humanitarian awardee in American Academy of Ophthalmology last year for his work in ROP. Now we will listen him. Graham, it's yours.
Thank you. Thank you for that lovely introduction from here in very hot Philadelphia. It's just beastly at the moment here. I participated in all those studies you talked about, but not a principal investigator for all of them. So just for clarification. Can you see my slides?
We can.
Something went away.
Please try again. Please try again, Dr. Pri.
Yeah, updated.
The lovely part about Zoom is sometimes you lose yourself. Can you see my slides?
Not yet, Graham, no.
No, no.
We just share your screen, I believe.
Sorry.
You have the little Zoom button.
Green
And
one, say share screen.
yeah,
Oh, I'm looking.
Okay.
do you see the do you see us or yourself? on
Not
this?
anymore.
Okay, do you find on your, the bar on the bottom, a little blue thing that looks like a video camera?
Graham, would you like me to skip yours after Mariana's?
Let me
Let me check one more.
that would be fine because it looks like
You should have a share screen
I go to
icon.
your screen. It doesn't.
Then click share. You click shared screen and then you pick what you want, and then it should have something on the right that's red that says share.
It wants.
Actually, we have done it before, but it's
Yeah,
okay.
we did it before. Share screen, and it takes me to Dropbox. Jesus Christ.
Oh, it's
Hmm.
interesting.
Interesting.
Maybe
Okay.
this will-
Yes.
Yeah, yeah.
Yes.
Okay,
Yeah.
now we
Now-
can see your
Now-
Dropbox.
You may change your screen as PowerPoint
I'm trying.
onto the bottom. Yeah.
Sorry.
It's okay. I think we are still on
I think
time.
you should go. For some reason, it's taking me to Google Drive. This worked the other day.
Yes, we tried it yesterday, but
Actually, there's a PowerPoint option.
on the bottom, yeah, we
Yeah.
can see.
You can select about PowerPoint
Yep.
on the bottom.
Yes, that's it.
If you just open your PowerPoint program,
You may
Oh,
close Google
Graham, you
Chrome.
can
Yeah.
pull up your
You
presentation.
may- yeah. That's the
There
option.
you go.
Please
Okay.
make it quick. Can you do it?
Slideshow.
Okay.
Okay, perfect.
That's a damn miracle. But
Great.
anyway, sorry. I am sort of proud to represent the group that is working on a third classification of the International Classification of Retinopathy of Prematurity. I'm the only individual who has served on 1984, 87, and 2005, and now the 2020-21 classification. These are the members of the ICROP 3 committee. You can see it's quite widespread. There are 14 countries represented, and there are 3 committees: the imaging committee, Mike Chang, Alistair Fielder is the regression committee, and I'm the acute phase committee person. As you know, disease classifications evolve. In 1953, the RLF classification was presented by Rees, and it needed to begin to compare regions throughout the world. In 1984, we developed the international classification defining peripheral and posterior changes, just in a pragmatic approach to schematics. 2005, we revisited the classification and further described posterior pole vessel changes and added APROP, aggressive posterior ROP. Now we're looking at incorporating into ICROP 3. What ROP has been used to is to describe the status of the retina. Retinal vascularization proceeds centrifugally from the disc out to the periphery, and the extent of that vascularization predicts outcome. We use 4 descriptors: the location by zone, severity by stage, extent by clock hours, which is less important nowadays with results of some recent studies, and the activity in terms of plus disease, which is posterior pole dilation and tortuosity, a term developed at Children's Hospital here in Philadelphia. The previous classifications were a consensus agreement among a group of ophthalmologists with experience and expertise in ROP. And it really has made an incredible contribution to the clinical world and to the research in ROP across the world. However, certain ICROP features do not have a precise anatomic or physiologic basis. They are a clinical tool. In revising the international classification, we wanted to revise it to reflect our current knowledge, to work through the main features of previous iterations of ICROP, and to distinguish certain limitations and begin to identify ways forward. In terms of location, there's 3 zones, 1, 2, and 3. Most posterior is 1, and it's a useful predictor of severity of disease. Currently, the stage of an eye is determined by the most posterior zone. And if you have a little dip into a more posterior zone, is it sensible to classify that as the more posterior zone? The way we are approaching at present, a notch of 1 to 2 clock hours into a more posterior zone does not determine the zone for the eye. An eye is determined by the overall location of the retinopathy. Stages 1 to 5, we're not suggesting they be changed. We are suggesting some more understanding over the last 10, 15 years of what aggressive retinopathy of prematurity is. APROP was introduced in 2005 and defined as a deceptively featureless, not usually progressing through the classic stages. And in my mind, it should likely be considered within the spectrum of stage 3 ROP, but at the extreme end of it. Since APROP, aggressive posterior ROP, is not always confined to the posterior retina, we suggest replacing APROP with AROP, aggressive retinopathy of prematurity, and recognize that stage 3 and APROP seem to be able to occur within the same eye. So are they part of the spectrum? Plus, pre-plus, and non-plus reflect the diagnosis of posterior pole vessels. They're a critical component of international classification and a term we developed here at Children's Hospital in the late 70s and early 80s. Currently, it's based on a qualitative assessment using representative images. And in the new classification, we hope to introduce a granularity with a series of images rather than just a yes-no image that reflect the indistinct cutoffs along the spectrum from normal to pre-plus to plus, mild, moderate, and severe. However, clinicians interpret plus, pre-plus, not plus, in great variation, and it's open to varying interpretations. With new imaging technology, we can develop quantitative assessments of vascular changes, and I think that's the way we'll eventually go. But I would warn, this is not routinely available worldwide. So how do we incorporate our new knowledge in clinical care where treatment decisions have been based on the clinical qualitative assessments? We're going to have to address that problem, and I don't think we quite understand where we need to go yet. A new addition to the ROP3 will be addressing resolution and regression of acute phase ROP. It's characterized by both vascular and ROP lesion components after acute disease. Spontaneous resolution and treatment-induced regression are different diseases, different processes. The rate of progression following laser and anti-VEGF treatment are quite different, and that needs to be recognized. We also need to be able to differentiate and define the difference between failure to respond to treatment and reactivation. Failure to respond usually occurs within a few days to a couple of weeks, and reactivation usually by 60 weeks PMA, but a lot of these are usually by and not necessarily data-based. What are the sequelae of acute phase ROP? We have vascular tortuosity. We have retinal residua, i.e. heterotopia is perhaps the most worrisome one with incomplete understanding of visual consequences. And an important thing we are seeing is peripheral avascular retina. After treatment or even just after term, what should we do about areas of avascular retina that persist after anti-VEGF or after prematurity? How do we manage those? We do not yet understand that. So what do we do now? Some ICROP features will be enhanced by ICROP3 by a clear description needed for clinical care. However, some aspects of ICROP3 require more robust data that we must accumulate over the coming years, and this will lead to a greater understanding and hopefully result in better care of our premature population. Thank you very much. I have no idea how long that was. I'm sorry.
Thank you, Graham. It was really great review of the ICROP studies and the novelties, and we will discuss at the end of the 3 talk, and we will now continue with the next talk, which will be given by Maria Ana Martinez Castellanos from Mexico, and she will talk about tips and tricks for safe and effective screening for ROP. And she is a professor in Association to Prevent Blindness in Mexico and National Autonomous University of Mexico. And she deals with ROP primarily and has many publications on this topic. Okay, Mariana, please go on with your talk. Just unmute yourself, please.
Y cuando yo me puse entonces yo le digo, bueno, no te lo pongas que por eso.
Can you hear me
now? Now we can.
Okay. So, hello from Mexico. It's a really, really cold morning to be summer. And, well, please mute your microphones so we don't have distractions. And these are my disclosures. And these are the people that we're working together now in trying to understand how life is changing for us with COVID and ROP in the NICUs and how we are going to take care of ourselves not to get infected, and how we're going to take care of our babies to prevent the infection and to see how we can help them. So the COVID pandemic has changed practices in ophthalmology. ROP is obviously not an exception. And the practices are in ophthalmology are changing. The American Academy of Ophthalmology is classifying ROP as an emergency procedure. Of course, babies are still born. They born. They don't care that there is a pandemic, and some of them are born. And the birth is premature due to COVID in the mother. So this is what we're going to study now. There is very little known about perinatal effects of COVID, and the available reports at this time, apparently babies are less affected than adults, but maybe that's not entirely true. The neonates have underdeveloped immune systems, and they are considered to be susceptible of contracting this virus. So they may acquire the infection through close contact with the patients, with infected patients like the mother. Apparently, we don't have transmission in utero or breast milk, but we have many babies that are contaminated, so we don't entirely know if this is true. The studies are limited in this aspect. The relevant aspects for ophthalmology include the non-invasive ventilation, the continuous positive airway pressure, the laryngeal mask, high-frequency oscillation ventilation, and high-flow nasal oxygen, like many of the babies that we see on the screen in the NICU. When the baby is crying, when a child is crying, the rate of inspiration and expiration increases to more than 200%. So the risk of having a contamination by a crying baby is really, really high. It's 200 times more. To make our diagnosis, we rely on physical examination in a very short distance to the patient. The Center of Disease Control and Prevention defines close contact to be 2 meters from the patient from a prolonged duration of more than 1 or 2 minutes. Sometimes it takes us more than 5 minutes. And if we're performing, for example, a laser, it takes us 30 minutes. I'm not talking about surgery. So we are in clear risk of contamination. The close proximity between the ophthalmologist and the babies under ventilation or crying during the ophthalmoscope examination or a portable sleep lamp may pose a risk of cross-infection. We can also infect the baby. The evidence so far indicates that conjunctival secretion and tears may have contained also the viral RNA of the virus, and healthcare workers should assume that ocular fluids from all patients are potentially infectious. For an in-office or in-hospital exams, diagnosis equipment and instruments should be cleaned, disinfected between patients using gloves. We have to wear these plastic gowns. There's somebody with the microphone on. The devices should be reprocessed. The examination stable surface in contact with patients should be disinfected. And the best disinfection is the bleach or alcohol solution over 70%. Binocular indirect ophthalmoscopes and lenses are not in direct contact with the skin or conjunctiva, but they are exposed to aerosolized particles. We just follow the manufacturer's instructions to clean them, and we can recommend bleach or alcohol to clean the surface. We also wrap in plastic the indirect ophthalmoscope, and we remove the plastic, like clean pack, something like that, every patient. The red cam piece should be cleaned with alcohol, and only the tip we recommend to plastic. Again, wrapping plastic the rest of the equipment. Reusable lid speculums and scleral depressor are considered semi-critical items because they are in direct contact with tears and conjunctiva. We require cleaning and a high level sterilization or disinfection, or using disposable ones. To screen the neonate should be in the incubator, or we suggest an acrylic box similar to the ones that the anesthesiologist use for intubate patients. This is the one that I use. This baby that I am injecting in this picture, that I am wearing all this gown, is the son of a mother that developed COVID. The mother passed away due to complications of COVID, and the birth was a premature birth because of that. The baby was negative all the time for the test, but this is how we dress to treat them. He developed ROP. And we have to limit the time spent with the patient. Regarding the treatment, we suggest administering anti-angiogenic therapy under topical anesthesia rather than using laser or using a general anesthesia due to the aerolized particles. To avoid contacts of the patient with the patient's parents, we prefer teleconferences or being behind a window. This is a very not really personal, but it is part of the safety. We do not recommend the use of direct ophthalmoscopes and portable slit lamps. The distance is closer. And well, we're going to talk about something more. Here is from the BBS, some triplets that were born here in Mexico. And we're going to talk about ophthalmological findings in premature babies with COVID. This is my city. I live in Toluca. This is the capital of the state of Mexico. We have 16 million inhabitants and a center hospital that is the hospital where we are a referral hospital. In this hospital, we found 11 premature babies, 3 male, 8 female, in age from 30 to 38 gestational weeks, examined in the NICU. All of them had severe acute respiratory syndrome, all of them intubated, all of them because of COVID. All tested positive by PCR. And here is a table of what we found. The 11 patients had problems in the eyes. The pictures are not really good because it's difficult in the area because of how they are covered. And this one was taken with a lamp for the dermatologist. But we can see that there is a hemorrhagic conjunctivitis in 7 of the 11 of them. We have chemosis. The eyelids are swollen. In the retina, we have very different patterns. There is one that seems to be like similar to toxoplasmosis. There are some cotton wools, some hemorrhages. Here we can see these like infraction, like non-perfused areas in the choroid. And this is beautiful. We can see this phenomenon in the angiograms of these babies. To our best knowledge, this review is the largest to date describing clinical features of SARS in infection in neonates. Although we still don't know how massively this will be spread around the world and affect the population worldwide, this data includes reporting children is so far reassuring. Due to the limited number of cases and clinical evidence, ophthalmologists should continue updating their knowledge and aware of the risk of a particular high-risk population like newborns and premature babies. And these are where you can contact me for any question. Thank you very much.
Thank you, Mariana. It was really interesting to see babies with COVID infection, signs of COVID infection in retina. And we will talk about that, discuss it with Graham also, but I just want to go to the next one, next talk. That will be given by Professor Dr. Esin Koç. She is the head of neonatology department in Gazi University School of Medicine, and she is also the president of Turkish Neonatology Society. And she has special interest in ROP and has publications on ROP incidence in Turkey. And now she will talk about decreasing the risk of ROP development in neonatal intensive care units, first for pediatricians. Thank you, Esin. You can go.
Thank you for the kind introduction and also for the opportunity to take part in this course as a neonatologist. And sorry, but I'm trying to share my screen. Yes.
We work together with Dr.
Yes.
Esin in the same hospital in Ankara,
like
so it's
Graham.
my pleasure.
I'm trying to screen it.
We are trying to treat it, but
Yes,
you're trying to prevent it. So that's much important than probably to treat it.
Okay, here it is. Can you see it?
Yes, yes,
Yes,
perfect.
we can see it perfectly.
Okay. Thank you for being late. Yes, as you all know, recent advances in neonatal care has increased the survival rates for extremely preterm infants, but however, prematurity-related morbidities are still high, and one of them is retinopathy of prematurity, which has a great effect, lifetime impact on vision and ocular morbidities. The good news is it is a preventable retinal disease, but on the other hand, multifactorial characteristics of ROP and complexity of the disease make the prevention difficult. So neonatal intensive care units play a key role in preventing ROP, because neonatal care during the first hours and weeks of life determines a preterm baby's chance of avoiding ROP and its complications. And interestingly, ROP incidence varies not only between countries, but also between the NICUs in the same countries. The importance of improved neonatal care in prevention of ROP is well illustrated by studies showing that in high-income countries, as you see here, severe ROP is confined to infants less than 30 weeks of gestation or under 1,500 grams. On the other hand, in underdeveloped countries or in low-income, middle-income countries, as you see, there are more mature babies, like more than 1,500 grams or older than even 30 to 35 weeks of gestation, who have even severe ROP. So we have to aware of major risk factors and identify them if you want to prevent ROP. The most important two major factors are preterm birth and oxygen therapy causing oxidative injury. These are very important, but several other factors like fluctuation in blood gases, like constant cycles in hypoxia and hyperoxia, and intermittent hypoxia. These are itself major factors, risk factors of ROP. If the baby has comorbidities of other premature diseases like pulmonary complications or cardiac or neurologic complications exist, then the risk of ROP increases. And inflammation due to infections like necrotizing enterocolitis, sepsis, fungal infections make the immature retina more vulnerable to oxidative stress. There are some points that we cannot change, like gender, ethnicity, genetic and epigenetic factors, but also low caloric intake, which causes poor weight gain, is also very important as a risk factor in ROP. Dysregulated growth factors, either excess or lack of these factors, are the other risk factors, I can say. As Turkish Neonatal Society, we conducted a trial which was published recently in British Journal of Ophthalmology to evaluate incidence, risk factors, and severity of ROP in Turkey. It was a prospective multi-center study from 69 intensive care units from all the countries, and more than 6,000 infants enrolled in this study. Unsurprisingly, the babies with any stage or severe ROP were more mature than in high-income countries. There were a lot of babies, more than 32 weeks of gestation or more than 1,500 grams. The independent risk factors we have identified were lower birth weight or shorter gestational age, total days of oxygen, late sepsis, 2 or more red blood cell transfusions, and relative weight gain at 28 days of life. Sorry. The first hour of life is called as golden hour because in this hour there are many low-cost interventions and these may improve the neonatal care and outcome of the baby. So in this intervention, these interventions include administration of antenatal corticosteroids to the mothers before preterm delivery. This intervention reduces not only mortality but also the risk of ROP development. Delay in clamping the umbilical cord and keeping the preterm babies warm. These are indirect interventions to reduce ROP by keeping the baby stable and preventing excess oxygen administration. We know that there are a lot of meta-analysis that shows lower oxygen concentrations improves the outcome, but at the same time may increase mortality. So in the delivery room, resuscitation of preterm babies with FiO2 of 30 to 40% are and reaching to a target oxygen saturation to 80 to 90% within the 5 minutes after birth is recommended by European Resuscitation Council. So we don't need to resuscitate the preterms with 100% oxygen. And controlling the oxygenation beyond the delivery in the neonatal intensive care unit keeps a challenge in neonatology, because we know that excess oxygen can damage organs of the premature, but a low oxygen saturation can lead to increased mortality. So NeoProm collaboration studies enrolled almost 5,000 babies, extremely preterm babies, and the main results from these meta-analyses are like that. In a low oxygen concentration, the incidence of ROP decreases. However, the mortality increases. So based on these results, European guidelines and American Academy of Pediatrics recommended the oxygen saturation targets not under 90%. And we should tight the alarms very close to the recommended oxygen saturations. But these results always come from high-income countries. So World Health Organization recommends the lower targets of saturation, less than the other recommendations. They recommend 88% because in these countries, more mature babies they can have severe retinopathy of prematurity. There are several very low-cost practices in the neonatal unit. We summarize them as points of care, and they can indirectly prevent development of ROP. These are pain, avoiding pain, infection control, nutrition, temperature control, and supportive care. So we try to keep the baby stable and reduce the supplemental oxygen, especially family-centered care, kangaroo care, and breastfeeding. These are important interventions, simple, low cost, but really effective interventions. So to prevent poor weight gain, which is an important major risk factor, we should start enteral and parenteral nutrition as early as possible. And there are meta-analysis showing that breastfeeding potentially plays a protective role in preventing any stage of ROP and severe ROP. So supporting breast milk is very important. There are pharmacologic interventions, but none of them have been supported with high quality evidence yet. So new trials are needed for these interventions, but I may put caffeine to a special place because it is one of the most used drugs in the neonatal intensive care units. By preventing intermittent hypoxia, apnea, caffeine has shown to reduce retinopathy of prematurity in most of the trials. So as take-home messages to prevent ROP, high quality antenatal and neonatal care is very important and essential. Delivery room management with resuscitating babies 30 to 40% FiO2 and target oxygen saturation at 80% within 5 minutes after delivery is very important. Again, NICU management, optimizing target oxygen saturation levels, monitorization of oxygen very strictly, and tight alarm limits. These are very important. And besides, optimizing nutrition with early parenteral and enteral nutrition, promoting and supporting mothers to give breast milk to their babies, and reducing risk for infection, both antenatal and late sepsis, and also reduce blood sampling to avoid unnecessary transfusions are important points at present. Thank you.
Thank you, Esin. It was really great sum up for the pediatrician's view. So now we have completed the first session and we will have a discussion about these three topics. I'd like to again call Graham for the discussion, and I'd like to ask the first question to Graham and then he can continue with the discussion. Please unmute yourself, Graham. I just want to ask you, what do you think about further staging of stage 5 eyes? We have discussed this during the ICROP meetings. What do you think about that?
I don't think I didn't want to talk about that today because I don't think we've reached a resolution on how to address it. One of the problems with the stage 4, stage 5 issue is there a combination both of acute phase disease and transition to resolution, regression, detachment, whatever. And I don't think we have a good way of describing that yet. And therefore, I didn't discuss that today. Personally, I think being able to say it's a total detachment or not a total detachment by whatever means you need to find it is an important aspect. You have different feelings about that. You feel that if we can see the disc, when we think there's a total detachment, has a different implication. Not being a retina surgeon, I don't know. Tony, what do you think?
Okay, we can ask Tony again. Okay, because what I feel is when you have a baby with a recent stage 5 disease with total retinal detachment, but you can still see the retina, not the optic nerve, but the retina, the posterior retina, that means that it can easily be managed. But if you see a leukocoria, you can't see the retina, and then that means something else. So the prognosis of these eyes are completely different. That's why we are just discussing these points. It's very hot topic at the moment, but I just want to hear that. Tony? Okay, you can go on, Graham, for discussion.
I was interested in the neonatology, in Dr. Koch. Guidelines are guidelines. And I don't think we as ophthalmologists are aware well of how poorly the babies comply with your guidelines. The babies get sick. The babies don't really pay attention to guidelines. We do. And help us as ophthalmology people to understand what percentage of the day are babies within the guidelines, whether they're the European ones or other ones.
Yes, you are totally right. Studies, actually in Turkey, we have guidelines to recommendations, not only for ROP, but for extremely preterm birth weight babies. But studies, even in high income countries, show that for infants on supplementary oxygen, compliance with the target oxygen saturation was about 30 to 40%. So we set the targets, type the alarm limits, but it doesn't mean anything because especially in overcrowded units, and if there is the number of the nurses is not sufficient, it means nothing. Here the key role is nurses. It's very important because sometimes there are many small babies in the NICU and the alarm sounds, but no one can go to the incubator and sometimes someone comes and switch off the alarm and return back to the work because there are a lot of things to do. So in neonatal intensive care units, an experienced nurse should not look after more than 2 babies in order to type the alarms and try to fix the oxygen saturations, but it's not enough. Yes, you are right. If the baby is sick, if the baby has comorbidities, if the baby has infection and other complications, it doesn't mean anything. And at present, we don't know how to prevent ROP yet.
Mm-hmm.
Yeah,
it's very limited.
Yeah, I think this reminds me of a visit I made to a nursery in Peru about 15, 20 years ago, where when I talked to the nurses who really are rendering the care, they would turn all the monitors off, the oxygen monitors off, when they needed to take a rest during their 24-hour shift. So you would have a nurse responsible for a baby or 4 or 5 or 6 babies for 24 hours.
Yeah.
And she would just turn off the monitor. So I think it just highlights the need for the teamwork that's necessary, because better oxygen manifestation care will lead to better pulmonary outcomes, better CNS outcomes, and better ROP outcomes, one would suspect.
Yes, definitely. Yes.
There are some questions from the attendees. From Canan Türk Yılmaz is asking, what's the incidence rate of COVID-19 infected retina ophthalmologists in your country? She's asking to the panelists. Is there anybody to answer? COVID-19 infected retina by ophthalmologists. Susanna, 0. And anybody else? I have never seen, maybe we don't realize yet, but I didn't see any COVID-19 infection in retina till now. We have, there's a report with PEM-like lesion in retina from US, I guess, but I didn't see anything like that till now. And another question is there, Esin Koç mentioned about caffeine for treatment of ROP. How does she recommend it to be administered? Advising mother to drink coffee by Ahmet Polat, Osman
Yeah.
Ahmet Polat.
We usually use caffeine just after birth, at the few days after, within the few days, to prevent bronchopulmonary dysplasia and apnea, just like for other complications. But then studies have shown that this administration of caffeine also reduces the incidence of severe ROP too. So I don't know if mother drinks coffee before birth, if it works, I don't know. But just after the birth, we administer caffeine.
Okay,
Thank
you. And another question by Pedro Matar to Mariana. Is there any change in the screening follow-up in the so-called micropremies, birth weight less than 800 grams and 26 weeks to Mariana?
Look, we in Mexico, we have very few babies that are
Like
born
that.
like micropremises like that. Usually they passed away. It's not like in more developed countries. But the screening follow-up is the same as the international guidelines. We don't make any change when we do have babies that's small as those.
Okay. May I ask you another question, Mariana?
Yes.
You have talked about the screening, but what do you do if you have still a persistent avascular retina beyond 40 weeks in zone 2? So how do you screen these babies?
We wait. We don't do laser or nothing. We wait.
I mean, 2 weeks, 3 weeks apart, but still avascular. So what's your...
In our patients, we don't do laser ever. Not 2 weeks, not in 50 weeks, or not in the next year, unless they actually develop a hole in the retina, and a lattice in a vascular retina, or something that demands laser. And it's very important for the audience to understand that something is ischemic retina, and it's a very different feature and a vascular retina. And it's not exactly a vascular. They have these capillaries between the retina and the choroid, but they don't develop the large vessels. But this is different. If they have ischemic retina, the ischemia is like a fire. It's really very obvious that that eye is suffering. But a vascular retina is completely different. But there are two groups: the ones that treated and the ones that don't. And I think that only time will give us the answer of what to do with these patients.
I just remember Dr. Tasman in one of his books in the early 70s saying that some of the premature babies that he observed still had avascular retina when they were 2 and 3 and 4 years old, and he did not treat them. And up until his death a couple of years ago, he said the same thing.
Mm-hmm.
Yes.
Okay.
And
okay. Mariana?
Later in the PAO webinar, in like 6 hours, I will be presenting adult ROP, and as a case series of adults that never were treated, and they have this avascular retina, and some that may develop rhegmatogenous retinal detachment because of little holes or things, that because we have to understand that ROP is a lifetime disease. It's
right.
not just in the first 50 weeks. No, it's a lifetime disease. And I will be presenting that. If anybody's interested, you can put the PAO webinar later.
Actually, that's my topic for today, so we can discuss it very nicely then. Thank you. And Graham, you want to ask anything else?
No, I think we can move on.
Okay, thank you for the discussion, great discussion. I think we can move to the next session. Now we will start with Parag Shah from India. Are you here, Parag?
Yeah. Am I audible,
great.
Sengul?
Hi, how are you? Very nice to see
I'm good.
you.
Nice to see everyone here.
Thank you. He will talk about oxygen-induced retinopathy today, and he works, he is a consultant in pediatric retina and ocular oncology department in Aravind Eye Hospital in Tamil Nadu, India. And he has many publications on ROP, and he has many insights about oxygen-induced retinopathy. So we are waiting for your talk. Thank you.
My slides visible, Sengul?
Yes, we can see it very well.
Okay. So at the outset, I would like to thank Sengul and the colleagues for inviting me to be a part of this webinar. And I'll be talking about this a little atypical topic, the oxygen-induced retinopathy, for a clinical forum. So I don't have any financial disclosures to reveal. So oxygen-induced retinopathy is traditionally the disease which has been induced in the lab animals, the mice, the dogs, the rats, rabbits, even monkeys they've tried. So before I move on to my next slides, I just want to declare that I have no experience of having this oxygen-induced retinopathy in the human, I mean, in the animal model. I'm not attached to any lab. So it is mainly my clinical work. I'm mainly a clinician, and I'll be just trying to prove a few facts that and try to answer this question: that is oxygen-induced retinopathy real in humans? And to answer that question in a simple way, it's going to be yes, it is possible. And I'm just going to reveal a few facts which I have collected during my practice over a period of 2 decades, that why I think it is very much possible. Now, going down the trip, down the memory lane in 1940s and 50s, there was appearance of the disease of retrolental fibroplasia. And why did it appear during that time? And we all know it was because of the introduction of the oxygen incubators there during that time for the care of all the preterm babies. And then they saw the prevalence of this disease going up. So that was the first epidemic of ROP in the 1940s and 50s, where 7,000 children went blind. And then in 1956, when the cooperative study of retrolental fibroplasia was published, and then they recommended that the oxygen concentration should be less than 40%. And that ended that epidemic at a very happy ending, and they did not see the disease after that. Now, why was it called retrolental fibroplasia back then? Obviously, because they used to see a white reflex behind the pupillary area, and the clinicians were unaware of the retinal changes happening before the appearance of this white mark during that time, because indirect ophthalmoscopy was very primitive, leave alone digital imaging, what we have right now. Having said that, there were a few clinicians like Arnold Patz, Ashton, and many other colleagues of his who could peek inside the eye. And this is from an article in 1968 by Patz, that they observed severe vasoconstriction in the preterm babies who were on because of hyperoxia and their possible role in pathogenesis. And not only that, that after the marked attenuation of the retinal vessels prior to the development, there was a dilatation and tortuosity of the vessels. And this is from the same publication, an artist drawing what they have shown here. There was no fundus imaging. This is the normal retina, and this is the retina showing the sclerosed vessels in a baby who was on 70% of oxygen at 4 days of age. And after this, the babies used to develop the tortuosity and dilatation as shown in this figure. And in 1953, they even tried to classify the retinal fibroplasia much before the ICROP1 classification. And they named this tortuosity and dilatation as a stage 1 RLF at that time. So this is the graph showing the epidemics of ROP and the first epidemic which peaked. And then it really came down by 1960s and 70s, it was all over. And actually the oxygen-induced retinopathy, these, if you consider these, the red arrows as the animal experiments which were carried out, they were all carried out during the downward trend of the disease, when the disease was really actually dying out in humans. And that is why the interest in this model was reducing. And by the time they could come out with a good replicable model, which was given by the Louis Smith and Gerard Letty way back in 1996 and 94, by that time, the retinal fibroplasia was already over and out with, and they came out with these OIR experiments in the laboratory animals in 1994 when the second epidemic had already set in. So these are the two popular models, the mouse model and the dog model. This is by Louis Smith and the Gerard Letty group. And what is the difference? Well, this is the mouse model where the 7-day mouse was chosen by the Louis Smith group. And that is because at 7 days, the hyaloid vasculature of these newborn mice had totally regressed. And they were showing immature vessels, what you see in a newborn preterm babies. And then after the day 7, they were put in 7 days, put in oxygen for 5 days, followed by 5 days in room air. And at 18 days, when they saw there was a severe non-proliferation area posteriorly and new vessels, which was a very typical of the oxygen-induced retinopathy. But the good part of this disease in the mouse is that it starts regressing on its own after the 18th day. And by the day 30 and 44, it totally vascularizes without leaving any cicatrization or any mark and without any treatment. And why is that? And this is from her article only, the Louis Smith article, that they chose 75% oxygen because they did not want to give rise to any cicatrical changes, and they wanted to just develop the new vascularization retinal for the drug testing, because when it goes through a cicatrical disease and retinal detachment, it is irreversible, as we all know. So that's why they came up with a model which has some chance of coming back to normal, and they can try the drugs. 2 years later, in 1996, the Gerard Letty group, they published with the oxygen-induced retinopathy in the dog model. And this picture shows in the room air, the vascularized retina in the dog, newborn preterm dog. And this is after 4 days at 100% oxygen. There was severe capillary dropout areas seen. So in the dog model, at the air, the dogs were having 62% vascularization. And within 4 days, in keeping in 100% oxygen, it reduced to almost 12%. And the sustained breathing resulted in 55% loss in the total number of cells and demonstrating cell death. And then they concluded the dog model is well suited for experimental studies for ROP than the mouse model. But then we all know that the dogs are expensive and the mice are much easier to handle. And that is why the mouse model is more popular. And nobody wants to see a cicatrical disease in an experiment where you can't test your drugs. So ROP is one of the few diseases, or probably the only disease, where the animal model accidentally proved the cause decades after the actual disease was totally eradicated from the humans. And the animal OIR model in the mouse was not created with the intention to support that oxygen concentration causes retroretinal fibroplasia, but it was developed for a different reason, which was to try the new drugs. As retroretinal fibroplasia disappeared even before the ICROP, there is no documentation of this disease in any of the ICROP classification. And obviously, it is totally missed out in the older classifications because the disease never existed when the ICRP was formulated. So now coming to the question, does oxygen-induced retinopathy occur in human neonates? Well, it does occur, and when we have seen that compared to the dog and the mice, unfortunately, we are more closer to the dog model, and I just wish that we were more closer to the mouse model where it regresses on its own, but it's not so. So these are a few pictures of the third epidemic of ROP, which we are seeing in India and other developing countries, where you see this severe APROP-like pictures. And these are the pictures from our initial publication, which we published in way back in 2005. And we named it as a fulminate ROP because APROP name was not even devised at that time when we submitted for publication. And of these babies, the mean gestational age was 32 weeks and the birth weight of more than 1,500 grams. And they were really big babies also getting this bad type of fulminate disease. A few years later, in 2012, we came up with the next publication, but then we named it as an aggressive posterior ROP because the reviewer was very keen that it has to be an APROP and we cannot put as oxygen-induced APROP or oxygen-induced like APROP. So we had kept this, name as APROP, but in larger preterm babies. And these are the few pictures in that publication. But what we did different in this publication is that we did some fluorescent angiograms. And you can see the fluorescent angiograms of these babies. There is a total loss of capillary loss way back till the optic disc, what was seen in the animal models. This baby was born at the gestational age of 33 weeks with a birth weight of 1,625 grams, and 100% oxygen was given 12 days after birth. And these images were taken 10 days in room air, which is a typical showing the OIR model in the animals. So all these babies came with these bad NICUs, which use using this non-rebreather funnel mask 2 to 5 liters per minute immediately after birth for 3 days or longer. And we noticed this, that 75% of these 99 babies had a loss of vascular retina. And how we came to know is our fellows used to go in the NICU and they used to screen for babies for ROP, and 67%, which was zone 2 in the NICU, when they came back to Arvind Eye Hospital, within 2 weeks' time, they had lost the vasculature, it had become a zone 1 disease, and 8%, which was zone 3, became zone 1. And all had severe plus disease when they came to the hospital, which was after the room air. And all the avascular retina was seen in zone 1. There were loops of large vessels reaching periphery, and few even till the aura, especially on the nasal side. And this is one of those pictures where you can see the avascular retina is right here, but the loops are going anteriorly, and we know these are all the capillary dropout areas and sclerosed vessels. So this is typically what we see in the oxygen-induced retinopathy model, even in the animals. So what we did is we started recommending to altering the oxygen delivery, and we told them to stop using the funnel and follow the good NICU's practice of using a hood, which is a simpler form of blending the oxygen, which is a crude way, but it reduces the concentration by 30 to 40%. And in the following year, in those particular NICUs, from 30%, it went to 0%. We could not see any disease of APROP from those NICUs. Again, this is a picture taken from the 1968 Arnold Patz article. And just to show you the figure legend, this is a stage 5 retroretinal fibroplasia case in a nursery which called attention to the oxygen of having funnel over mouth for added oxygen while in incubator. And unfortunately, this is what we saw 4 decades after this, the oxygen funnel there. But the only difference here is that we could document the retinal changes happening before the child developed the retrolental fibroplasia or the stage 5 ROP. Now, are we entering a 4th epidemic of ROP? Now is the era where everybody talks about the zone half disease, is where you see these, the vessels are not even reaching till the papilla, even till the fovea. And what we call is the no zone disease. This is a case where, the vessels are not even seen anywhere in the retina. And these are the smaller babies who are now who are surviving in these NICUs, but still end up getting 100% oxygen. And they get the most severe form of this disease. And that is what I think we are going for the totally different form, the 4th epidemic of ROP. So where is all this confusion in the pediatrician's mind and even in the ophthalmologist? The confusion is because between the oxygen concentration and oxygen saturation, which is both in percentage form, which are mentioned. All the older diseases of retrolental fibroplasia and the animal OIR diseases are focused on oxygen concentration and concluded the more the oxygen concentration, the worse the disease. If you go beyond 40, 50%, 60, 75, 100%, it's going to get worse every time. However, the latest studies which were done, all in the developed world, the boost, support, whatever trials were done on the oxygen, they were concentrating on the oxygen saturation, knowing that the oxygen concentration is going to be less than 50%, and the saturation, that is where the controversy is, what is the type of saturation required, and we all agree that it is between around 85 to 95%. So that is what the older studies, the oxygen-related studies it concentrated on the second epidemic of ROP. And just to bring out that fact, the pulse oximeter was developed only in 1972, and only when 87 it became popular. So only during that time that oxygen saturation was monitored, and during the era of the retrolental fibroplasia, or even in the oxygen OIR models of the animal, nobody sees the saturation. It is related to the concentration of the ROP. In India, unfortunately, and many other countries, 100% oxygen is still used in several NICUs. And in spite of having pulse oximeters, the saturation is kept between 95 to 100% in these babies. And this is like a double whammy for these. What's name? You call it a retrolental fibroplasia, you call it oxygen-induced retinopathy in an animal, or you call it fulminant ROP of APROP in big babies, or you call it as APROP in small babies. It really doesn't matter, because it is the spectrum of the same disease, and all appear when the concentration of oxygen is more than 75%. I'm talking about concentration, not the SpO2 or the saturation. So this is how I start looking at the end of my talks and giving a take-home message, especially when I'm in a neonatology forum. And the 2 points I'd like to highlight: how do you prevent ROP? And when I mean ROP, I'm talking about the big babies ROP, the first epidemic, the oxygen-induced ROP. Is 100% oxygen should be avoided. It should be banned, actually. Oxygen blended with air, and the concentration of the oxygen should not be more than 50%, ideally less than 40%. And the saturation should not go beyond 95%. And there is no better time than to stressing this fact in this difficult pandemic times, that prevention is better than cure. This epidemic of ROP may not be as hot or as widespread as the ongoing pandemic of COVID, but then this is a simmering epidemic which can be really extinguished, which has been going on for a long time, by just following these 2 rules. And then that will get the end of this, actually, oxygen-induced retinopathy. So I thank you for your patient hearing. Happy to take some questions.
Thank you, Parag. Yeah, we will have some questions, of course. We already have some questions in the question and answer box, and I would ask all the panelists if they want to reply, give an answer to those questions. Please check the chat box and question and answer box, and you can write your answers, especially if it is related with the previous session. Okay, so thank you for your talk. We will now go on, and the next talk will be given by Dr. Audine Berrocal from Miami, Bascom Palmer, and she will talk about differential diagnosis of ROP, especially the ROPER and other mimickers. And she works in Bascom Palmer Eye Institute in Miami, and she has lots of publications on pediatric retina, and I had a chance to see her clinic for a short time during 2004. So it was really nice to be with her. Thank you for accepting to talk here, Nina. Are you there?
Thanks. Can you hear me?
Yeah, we
Great.
can hear you very well.
See my screen?
Yes, yes, we can.
Perfect.
Perfect.
So, thank you, Sengul. And I think you were in 2004 when I had almost started at Bascom. I think I started in 2000. So you caught me in the beginning. But just a little thing before I start. Yesterday I was in clinic and I saw a patient that you treated, an ROP patient that you treated in Turkey, and they're doing quite well. So just letting you know. But today I'm going to talk about, the differential diagnosis of ROP. and the mimickers of ROP, if you may. So, ROP, as we all know, is a disease of prematurity, but, we have these avascular retina and other diseases that we see when we see them as infants, as young kids. And many of these diseases can be such things as fever, Norris disease, incontinentia pigmenti, and even Coats disease in some cases can be very difficult to differentiate between one and the other. And especially not, in regular Coats too, but also in those telomere, which are telomere diseases that are a little bit, harder to find because they're so rare, like this keratosis congenita and Coats plus disease. So in ROP, we know premature birth. I think most ROP, but not all, is pretty symmetrical. It's very consistent at the time of presentation, as we know, with the median age of threshold at 36 weeks, even though in AP-ROP that could be a little bit earlier. And the natural course of ROP is that the majority of ROP regresses, and it also regresses when we treat it. And we know that ROP ends, and I agree with Mariana, ROP is a lifelong disease, but it ends in the vascular component of the disease. This is a case of ROP. You see how beautiful it is, the montage. You see that it's very symmetrical, and when you do the angiogram, you see that it's pretty symmetric. I mean, there's certain differences, but the gist of it is symmetry. So how do we differentiate these other diseases that we talked about with ROP in the presence or a history of prematurity, which is what makes it a little more interesting? So let's start with fever, and I always think of fever as it looks like ROP. The babies are not necessarily premature, but in prematurity it makes it a little trickier. It is progressive, it is asymmetric, it is exudative, and remember that ROP doesn't really exude until you have a tractional retinal detachment much late. So exudation early on is not necessarily a sign of progression of ROP. You can see telangiectatic vessels, and you have many times a family history. So what if they're born prematurely? And classically we differentiated fever from ROP just by the timing of birth, but I think it's the time of birth, the family history, and the length of the clinical activity. And in my mind, it's like when I teach my residents, it's like ROP that doesn't go away, or ROP that progresses. It exudes late and it has dragging of the macula. So what helps me differentiate these two, and it's really angiography. And I think that, in the United States, digital wide field fluorescein angiography has become the standard of care in the diagnosing and management of all these pediatric retinal vascular diseases. So somewhere along the way, I decided to look at these cases that I believe were fever in the presence of prematurity. So it was in my own NICU, many of them that I have followed throughout. So I had, I was privy to their development into something that was not ROP. And I was able to, I decided to coin this something called ROPER. So is it ROP versus exudative retinopathy? And I identify at the time when I did this study nine patients. And these are some of the characteristics that we were able to define. And this is ROP, and you see ROP is very symmetric. Even by angiography, is the actual ridge is very symmetric. But in fever, you can see that you have irregular sprouts of vascularization, you have pruning of the vasculature, and you have segmental vascular leakage. You also have vascular loops with tangles beyond the edge of the neovascularization, and you can have small loop shunts with irregular branching and segmental vascular leakage. And even further, you can have pinpoint hyperfluorescence with vascular pruning and vascular loops extending into the avascular zone. So as I stated before, these are the things that we identify angiographically in those patients that had ROPER. So, fluorescein angiography is the key in the diagnosing of ROP versus fever in my experience. So let's take you through some cases. This is a baby born at 35 weeks of gestation, 1,800 grams. So that right there, for me in my NICU, is not a case that's going to have bad ROP. I know in the rest of the world that's different. The case had mild exudation. The baby was treated with laser in the unit. At the time, I did not have any angiography that I could do, but the baby had these exudative components that I did not think this was ROP. The baby was lost to follow-up and returns 4 years later with an exodeviation in one eye. These are the original pictures in the NICU. And you see that this doesn't really look like ROP. You know, you don't have enough plus disease for that amount of exudation and blood, so a little atypical. This is when they present 4 years later, and you can see the laser that I did in the NICU, but you see the vascularity that is posterior to the laser, and you see that we have exudation and a vascularity posterior to that laser. So this is their last visit, so we just complemented the laser, added a little bit more, and also I like to treat these cases with bevacizumab. Second case, a baby born at 23 weeks of gestation and 550 grams, never treated, referred to me at age 2.5 for evaluation of decreased vision in one eye. And this is what we have in the right eye and the left eye. And of course, we do an ultrasound that is negative for any retinal detachment or masses. And this is the fluorescein angiogram of that eye, and this is what we find in the other eye. And you can see that the diagnosis is really in that angiography of the left eye. Another case, born at 34 weeks in the Dominican Republic. This baby was diagnosed in the Dominican Republic with ROP and plus disease. It was treated with IV ranibizumab in the Dominican Republic, but at the age of 74 weeks, the referring doctor said that they weren't sure to do laser or not do laser, and the family wanted a second opinion, so they came to Miami. And these are the color images of the eye, and this is the fluorescein angiography, and you can see that there's a vascularity of the retina. So if you take a baby that's that age and you treat it with ranibizumab, that baby should vascularize. So there was something slightly not quite that made sense, and this is the OCT, very nice. And this baby, we ended up doing genetic studies and has a ZNF408 mutation, which is in the zinc finger protein, diagnosing this kid with fever. And actually, it's autosomal dominant, and the mother has it, and the other sibling also has it. So for fever, angiography is key for the diagnosis. Remember, it's inherited in multiple ways, autosomal recessive, dominant, X-linked, and it can be a de novo. And, you know, genetic studies, I think, is essential. Now in the United States, we can do 200 genes for free, which is great. And, you know, there are more mutations identified all the time. And I think Yokonawa has a new paper that came out with a mutation, the CTNNB1 for fever. So then we can talk about telomere dysfunction, and these are cases that look like coats. They're vascular, but they're a little bit more than that. And you know, telomere diseases, patients usually, unfortunately, die. So it's a very, very difficult diagnosis to give. So this baby was born at 34 weeks of gestation. Actually, the mother is a pediatrician, and born 2,500 grams. She had a previous pregnancy, stillborn at 34 weeks. So at 9 months of age, the baby presents with an abnormal red reflex. And this child has a CTC1, but he has 2 mutations. So this kid has been diagnosed with Coats plus and this keratosis congenita. And these are the images at 9 months. You see the amount of exudation and the amount of telangiectasia. But the other eye, you can see that it's avascular. And you see these loops going outside all this with that amount of avascularity. So we were able to follow this kid, treat it aggressively for a whole year. And this is that child now at age 9. And another telomere dysfunction, this baby was born at 35 weeks, referred at age 1 with bilateral hemorrhages and diagnosed with Coats plus disease. And you see also the amount of exudation in these children and the avascularity of the retina. But you see the avascular part looks very unusual with loops of vessels into the avascularity. And this is this child now at 5 years of age. And, you know, we always have to talk about incontinentia pigmenti. You know, I see a lot of incontinentia pigmenti. This baby born at 36 weeks, mom has a diagnosis of IP, and the baby was referred to me at 6 weeks of age for evaluation. And you can see here that there's some avascularity of the retina, but what's more impressive is that I treated, and when it comes back to me, it comes completely vascular shutdown in the right eye, and the only thing I did was laser. And you see that the left eye is very avascular, very significant in the supratemporal quadrant. So I started treating it with injections of bevacizumab, and you see there's some revascularization of the right eye, but obviously that eye doesn't have good vision, and we have the left eye. And I think, you know, what's important to always remember is many of these cases are diagnosed, misdiagnosed in the NICU with herpetic lesions because of the popular early lesions of IP. Sometimes it's 1 or 2, so you always have to remember to think of incontinentia pigmenti. And this is a case of incontinentia. You know, I'm showing you cases that not always you can have angiography. So these are cases that I treated before I had angiography in the OR. And one of the techniques that I always used when I was even lasering for ROP dark fundus, which is so hard to do, is to start at the aura and then start going posteriorly until you hit the vasculature, and then you know you're at the margin of that. And this is that case on the second visit, just trying to make my laser better. So incontinentia pigmenta, it can be premature or full term. It's asymmetric. You need to follow closely, especially the first 2 years of life. I've seen patients sent to me that in 6 weeks there's complete retinal detachments in one eye. So this disease is very aggressive. First 2 years, you really have to look at them, and I believe that you need a baseline fluorescein angiography to really understand what's going on. And remember, it's X-linked dominant. And to end, I think this is Norris disease, and this is a great case from Robert Sisk, who was my fellow, who's now in Cincinnati. And Robert, this is a patient that they knew the family had Norris disease, so they delivered this child at 34 weeks to be able to treat it and prevent the retinal detachments. Because, you know, as Tony and Mark Walsh and Kim have talked about, this is what you can get from Norris, which is a very aggressive detachment that just involutes and is very hard to treat. And many of these kids simply go blind. So family history is very important. Genetics are important. And remember, it's X-linked recessive, and it also comes with hearing loss. So in conclusion, good history is essential. Angiography is key for the diagnosis and for the treatment. Fluorescein-guided treatment is what I do, and I think it makes me a better treater of these conditions. Genetic studies, I do them now all the time because they're so accessible to families. Examinations under anesthesia for diagnosis and treatment should be done. You know, you should not shy away from an exam under anesthesia. And I think it's essential to work closely with a pediatric ophthalmologist, a geneticist, and a pediatric optometrist for contact lenses and visual development. Thank you very much.
Thank you, Nina. It was really great. And I hope we can again meet in ASRS and all other meetings together, and we can have pictures together, not virtually, but by person. Thank you. So we will discuss all these topics, but we will go on with the next topic. And this is imaging for ROP. And this talk will be given by my friend Leila Vazovic. And she works in Duke University, and she has lots of pediatric retina cases. And she has many publications, especially on OCT and OCTA in these pediatric baby eyes. Yes, Leila, you can continue.
Thank you, Azek. Thank you so much for organizing this. It's a true pleasure to participate, and I know it takes quite a bit of effort to put such a team together. It's truly an honor, actually, to be presenting among the team here. I'm going to share my presentation, and please let me know if you see my slides.
Yeah, we see your slide. Yeah.
Thank you so much for confirming. Well, thank you again. I'm going to touch base on imaging of retinopathy and prematurity. As you mentioned, I'm Leila Vazovic. I'm a pediatric retina specialist at Duke University. Let's move on. So ROP, as we know, is quite prevalent across the world. In the US, 15,000 very premature infants will develop ROP, and thousands of those will unfortunately lead to significant lifelong visual impairment and blindness. An ETROP study has really led to reduction of poor visual acuity outcomes, reduction of poor structural outcomes, and has really implemented some of the screening protocols that we currently use for care of ROP. And we typically rely on indirect ophthalmoscopy as being the gold standard in our bedside examination and diagnosis of ROP. However, that type of imaging technology is really NFOS viewing of us. So we are relying on some of the features that we see to tell really what's happening in depth in terms of retinal elevation. Fundus photography and OCT, as well as the other imaging modalities, have made this care of ROP babies and vulnerable patient population even more prevalent. And what are some of the imaging technologies we currently use in care of ROP babies? Well, we all this morning have seen a really quite a beautiful fundus photography images with typically RedCam type of system, and those also allow for fluorescein angiography. Portable OCT allows us to tell more depth information, as you can tell, and OCTA, primarily investigational, currently is gaining some traction in terms of understanding what the vasculature development is like in the periphery. We all use indirect as a way to screen these babies, but video indirect feature is nice because you can also record some of those findings and share with others. And I know while worldwide smartphone technology has really gained traction because it's so portable, lightweight, and so accessible to many, so telemedicine type approaches with smartphones are gaining traction as well. And then ultrasonography or UBM can help us really tell some of the retinal detachment features, and are often used in advanced cases where the view may be limited into the eye. So we started with having fundus photography with RedCam from Natus, but currently we actually have many other systems on the market with Panocam, Icon, and Neo gaining traction, and all of them have portability as the best feature of them, and potentially fluorescein angiography, and cost, of course, matters as well. And Optos or Optomap has really helped us identify some of the peripheral pathologies and gain insight into that. It is a system that's often used in kind of flying baby type position. And I know some of our speakers have very much had great insight with that in terms of getting wide field imaging and magnification of the retina. So what does the technology such as this or imaging of the back part of the eye allow us to do? Well, it really has allowed us to screen babies better, to organize telemedicine type programs to help really treat other babies where retinal specialists or pediatric ophthalmologists may not be available to do the screening. Has allowed us really to compare between the visits and see the progression of the disease, to diagnose better and stage disease better, to document, and more importantly, to communicate in terms of teaching efforts such as this one, or really communicate between the doctors as the patients may be moving to various parts of the country or the world. So telemedicine really is RedCam fundus photography type of feature. And it has, as I mentioned earlier, allow us to take care of the vulnerable patient population in some of the parts of the world where we had not had access before. But it really is, again, an NFOS viewing system and does not really give us much information about the depth features of the retina. So often stage 4 and 5 ROP are particularly challenging to diagnose on RedCam imaging. And I think OCT is quite helpful in those features. But also OCT may be helpful in correlating structural and vascular abnormalities, as well as correlating with visual outcomes as we're trying to study. So what does OCT tell us? It tells them some of the pre-retinal tissues, as you can tell in some of these images. We can see taut hyaloid and traction related to that. It will tell us inner and outer retinal features, such as some of these schisis features that you can see on OCT images, and then subretinal features such as fluid, exudates, and RPE changes. And it really has allowed us to potentially get better surgical outcomes by identifying the taut hyaloid and understanding that is a key feature that needs to be addressed at the time of the surgery as well, in order to release that traction better. And we currently use Duke Research swept source OCT system in some of the imaging that we perform in the NICU, but commercially available system is the Bioptegen spectral domain OCT system that you see on the right side. And how do we accomplish OCT imaging in the NICU? Well, we swaddle the baby. We do not use any lit speculum. No drops are given, and no non-contact system, as you can see here, particularly here, a Bioptegen system is used. And you'll notice there's no bright light associated with it. So baby is actually quite comfortable during that imaging. And often nurses remark that this is actually much easier on an infant than what we do with the indirect ophthalmoscopy. You'll notice that there is definitely a learning curve to obtaining these images, and we routinely have our experienced imagers obtaining this in the NICU. And what are some of the features we were able to identify with OCT imaging? So you'll notice on 34-week-old infant, the outer retinal layers are very much not present, while the 17-year-old child or older child will definitely have all the layers developed, such as adult. Here's another example of really poorly developed outer retinal layers. And in premature infants, we have found out that these layers will definitely develop with time, but there's a little bit of a delay on that development. And even the term infants, which typically should have all the layers developed, typically do not have it at the time of 39 weeks or 40 weeks of gestational age. What are some of the other features that were identified? Well, macular edema, which is present in about 40 to 50% of infants examined in the NICUs across the US, and it can be as mild as the image you can see in the upper corner versus moderate to severe. And really the impact of this on visual acuity is yet to be determined, but clearly it does not look normal. And what are some of the features that are associated with this? We are trying to figure out. What else can we see on OCT? Well, we can see vitreous opacity, subretinal fluid, traction, be it on the surface or potentially traction of the optic nerve, and those can be very much followed on OCT and assess whether there's distortion of the retina that may impair vision along the road. Now we're diving with our wider field imaging. We're now capable of getting peripheral images, such as in this 43-week infant who has clearly stage 3 ROP. On the SVP images, you'll identify tortuosity and dilation, but on OCT, as early as just even popcorn formation, you'll identify little nubbins on the surface. And now we're finding out that we can use this tool as potentially a screening tool in early diagnosis of neovascular ROP. So more information is to be coming down regarding that. I mentioned earlier that stage 4A and 4B on clinical exam, particularly on REDCam images, is very challenging to differentiate. Well, OCT will tell us that depth information to differentiate schisis in the periphery versus retinal detachment. This particular infant was referred for 4A ROP, and OCT clearly just demonstrated retinal schisis. Here's another example of schisis in the periphery versus an area of retinal detachment. And clearly the schisis is quite aggressive and approaching towards a fovea. So we may want to address this surgically, but OCT help us identify some of the kind of tractional forces, as well as really tell us that this kiddo may have quite a good outcome because it's not truly a full-blown retinal detachment. So how has OCT evolved at Duke? We started with the commercial system initially, well, really commercialization of the system in 2008 that became down the road Bioptegen system that we all can use. And now we have a investigational swept source system that you can see in the later images. This swept source system allows us to obtain these type of images. You'll notice they're much more wider field. There's more depth information with choroidal imaging. And we can really look at the periphery and create these 3D volumes that you can see on the right to identify neovascularization popping up and potentially follow with the treatment. OCTA can pretty much, very much be part of this investigation and can be captured in less than 6 seconds. So we're now currently really looking at development of the vasculature in the macula and the periphery, and my colleague Shi Chen is very much studying that. What are some of the other things we can do? We talked about very much the structural features and the thickness that we can identify from the OCT. We can see on these SVP images the dilation, tortuosity, and then neovascularization happening in the periphery. We can create retinal maps and follow the thickness maps over the time. Here are some of the OCT angiography features that I showed earlier. But I think the most interesting is really creation of these 3D volumes, which allow us to get not only depth information, really topographic information, and more so in the periphery, kind of follow the pop-up of those popcorn type lesions, neovascularization, and potentially treatment down the road. So my colleague, Cindy Toth, is leading a prospective study at Duke called Baby Steps. And the goal of the study is really for us to come up with novel bedside ocular neovascular imaging with hopes that this type of imaging will allow us to identify early indicators of ROP, or poor visual acuity in brain and neurological development. And as part of this study, we're prospectively enrolling patients, gathering information at the bedside in terms of infant health and ocular exam findings. We're doing simultaneously OCT imaging at each visit. And some of the babies are getting research MRI to help us really identify some of the correlation between this brain and visual acuity function down the road. And at 9 months, they're getting visual acuity testing with teleacuity and hopefully Bailey scores at 2 years as we're prospectively following these babies. So in summary, I've showed you some of the features of primarily OCT of ROP and how that type of technology can help us more identify feature and potentially find biomarkers for early identification of ROP and follow the treatment down the road. These images are very much, and research is very much a team effort. And I want to thank all the Duke Darcy lab members, as well as the Duke biomedical collaborators who help us come up with technology that you see here. But also really my colleagues, my dear colleagues, Cindy Toth and Shi Chen, who are pediatric retina specialists as well, leading these efforts, as well as our pediatric ophthalmology team, Sharon Friedman, Maisel Derry, and Grace Barkal-Porn. So thank you for your time, and we'll answer some questions.
Thank you, Leila. It was really fantastic. We will moderate the discussion with Nina. Nina, do you have any question to the previous talks? I mean, Parag, Leila, or you?
So Leila, I'm impressed, you know, I always tell you this, but I really mean it because I do OCT and I understand the difficulty of doing an OCT in a preemie. How long for the baby steps study? How long do you think it actually takes you to get really good images per baby?
So that's a great question. I think it definitely is a challenge. And as I mentioned earlier, we have dedicated imagers who not only image for the study, but pretty much all our infants. So we have 2 imagers who are very experienced in getting that. I think the key is kind of making the baby comfortable and doing it at the right timing. And with the current commercial system by Optogen, it definitely takes quite a bit. And we'll say 20 minutes at least to capture those and kind of assess. We're fortunate to have a research system at Duke, which is now much faster. It actually captures that image in less than 1 second. So it almost doesn't allow a baby to blink before we can capture it. So our time efforts on that have significantly decreased, and I would say probably about 10 minutes or so. Now, given you know, there's always swaddling and kind of positioning baby. I think positioning even with our exam is key, but even more so for OCT imaging.
We have seen real good images with baby OCT. So we try, but we can't get so nice images. We have talked like that. And the same question about Leila. And I want to ask you, Leila, I think that the OCT will be very important for ROP babies to discriminate between, you know, 4A and 4B. You know, sometimes it looks like 4A, but when you take an OCT, you see a shallow detachment in macula. So I think it's important to do that, but also to see the retinoschisis, because you see sometimes the retinoschisis like thing, but you're not so sure if it is retinal detachment or not. So I think in these things, it will help. What else do you think it's mandatory for ROP cases? I mean, OCT.
Mm-hmm. Yeah, and I think you point out very much the features that are quite helpful to understand, and point out some of the images of babies being referred for a surgical intervention where they very much did not have a retinal detachment, and potentially additional laser alone can be the treatment of choice. Currently, before any type of surgery intervention, even if baby had an imaging 2 days ago, I'll repeat it intraoperatively, because I exactly want to identify some of those planes that I need to address at the time of the surgery. In terms of the NICU, we are very much finding some features that are shared with you in terms of macular edema, in terms of some of the popcorn type lesions that are popping up in the periphery may have actually been missed, and we're finding out are potentially missed as part of the exam. So I think OCT will give us a more of a detailed view and some of the biomarkers that we'll potentially use as a screening tools. But you point out very much it's still very much in investigational stages, and us understanding how we may use it in the future. And we hope with the current study to come up with biomarkers or some of the pointers as to how OCT alone can help us.
Thank you. Parag, may I ask you a question? Or is there any question from the panelists? If not, I will just ask you, how do you treat these oxygen-induced retinopathies? I mean, do you do just anti-VEGF and just the same thing as AP-ROP-like disease, or do you do anything else differently?
Well, I prefer giving anti-VEGF, and especially with bevacizumab, because it has a longer duration of action, and then we just wait and watch, and we have seen that around 10 to 12 weeks, if there is a recurrence and if it has crossed well beyond the fovea, then we do a laser at that time. And if it still does not recur, and this is still a persistent avascular retina, we still prefer just to observe and wait and watch. It gets a little difficult later on to examine these babies, but yeah, we don't usually do an additional laser if there is no recurrence as such. But we keep a close follow-up.
Okay. Okay. Nia, Graham, please.
I just wanted to, Leah, it's so exciting to see the greater detail we're finding out about the physiology at the junction between the vascular eyes and the avascular retina. And that kind of takes me back to, how are we going to define the ROP stages 1, 2, 3, 4, 5? Because it's very apparent that with indirect ophthalmoscopy, 2 and 3 are pretty easy to tell, quote, easy to tell. But when you throw in some FA or your OCT, you clearly see that there's a much finer distinction that needs to be made. How are you going to think about addressing that?
Yeah, I think, I mean, you clearly point out that, and what we all know as we, take care of adult patients in clinic, we routinely use OCT, and OCT has changed the way we practice in adult world. It's slowly changing the way we practice in pediatric world. And the only limitation is, unfortunately, we don't have technology that we can readily image kids that's, kid-friendly technology. And I think we're slowly changing that. We will have to come up with actually more staging and defining disease by OCT as we come up with technology that is going to be readily available for all and easier imaging modalities for all. So we hope that, by coming up with faster systems, wider field system, and hopefully easier to use systems as well, which are lighter and kind of easier to move around. We're hoping to commercialize that one day and make it more readily available. But I agree, the OCT, I think, give us much more detail. So it will allow us to redefine disease and hopefully potentially manage these babies even better. So.
Thank you. And Parag, how does that fit into your world? How do these technologies fit into the world in India?
I mean, RedCam is there, and we have been using it, and it's the OCT is something which is costly and which we cannot afford here. Not only the financial implications, but the time. We have so many babies here. You can't just keep on doing an OCT for 20 minutes or 25 minutes for a baby. There are many of them waiting there, and we don't even have time to do a fundus imaging, REDCam. So we just do it only in babies which we feel require some documentation for presentations or just show the family. Otherwise, it's very difficult. So OCT is something which, unless it comes in a cheaper, portable, and a faster way, I think we are still a little off from these technologies right now.
Yeah, and I think similarly, we started with REDCam being, not readily available and expensive for all, to now having a NEO system, which is much more affordable. So I think, with collaborative efforts across the world, I believe we'll come up with cheaper and faster systems as well. So, but yeah, there's definitely a need for further development there. So. Okay. I have a question for Nina. Thank you for sharing those amazing cases. I always learn so much from your cases, and just really interesting findings. I know you elucidated in cases with IP, you recommend imaging right away as soon as you kind of meet the baby, it sounds like it, to get a baseline fluorescein angiography. How often do you follow them from that time point? And what are some of the parameters you may use to follow more closely or more further out, to about 2 years of age, as you mentioned?
I have to say that when we talked about this, we have to talk about Sandra Montezuma's paper that she gave us, guidelines of how to follow these kids. And I think it's the only guidelines that I know there are out there. But I follow them every 6 weeks for the first year of life, either in clinic or in the OR, depending on how the first fluorescein angiogram looks. And, I have the ability of doing REDCam in clinic on the baby, so I can actually look at all that and then decide when I have to go back to the OR. But I think the first year, every 6 weeks, and then the second year, depending on how it looks, I can progress that to every 3 months. But I think those first 2 years are critical.
And if you see no vascular features in the periphery on FA, you clearly demonstrated progression in one of the baby, quite rapid progression. Would you feel more comfortable? What's your comfort level about when it's fully vascularized?
Well, remember that fully vascularized, because I've seen it change so much where you start and it looks great, and then you repeat it a couple of weeks later and it starts changing. So I think you need a couple of fluoresceins in the first 6 months before you can actually feel that it's not going to change rapidly.
I have a question for you, Nina. Actually, I'm not familiar with telomere dysfunction, and I have seen really interesting cases from you. Can you tell me about the discriminating points? And probably I see, but I don't recognize those cases. So can you give me some clues about that?
Yes, it's interesting because the first case that I showed you, the very impressive exudation, the kid of a pediatrician, I started with that kid, and I remember doing the angiogram and thinking, this is so unusual. This has to be some fever-like. And it was not until that kid became, I want to say, she's 9 now. I think at around the time she was 5, she developed reticular rash, for this keratosis congenital. They developed this reticular rash. They have funny teeth. And I remember the mother saying to me, she has this rash. I was going to take her to the pediatrician. And then, I saw that and I go like, oh my God, I know what the diagnosis is and it's horrible. So in those cases, for this keratosis, some of the signs like the skin can come later, but I think the angiography is critical. In Coats Plus, those kids develop MRI changes early on. So the MRI is very critical. The hair looks weird because, they're kind of aging prematurely. So all those factors, but I think, MRI early in those kids that present with what looks like Coats that's bilateral, it's important.
Okay, very nice clues. And although it's not in the differential diagnostic list, I see peripheral avascular areas in PFV cases, posterior PFV cases sometimes. What do you think about that? Should we do anything for that, for those places? Should we do laser or just leave alone? I just leave them alone, but what do you do?
I've always left them alone because I've never had a neovascular component to it.
Right.
When it becomes difficult is when it looks like PFP and you're really dealing with fever with a very normal eye and a very abnormal other eye. So,
Yeah.
you know, I think you always have to keep looking at them and not discarding them because they look just like, you know, PFP, but I don't
Of
treat.
course.
It's PFP,
Okay.
I don't treat.
Okay, thank you very much. It was great discussion. Actually, we have some questions also from the attendees, but if we had time, we can probably discuss at the end of the whole session. And you can also type the answers just yourself if it is related with your talk. Okay, so thank you, Nina, Parag, and Leila for very great talks. So we will move on to the next session. The next session will start with Zuhal Özen Tunay, my dear friend. She's from Ankara and she works in Ankara Bilkent City Hospital. And she works only on ROP cases and for pediatric low vision rehabilitation. And she will talk about laser treatment for ROP. Zuhal,
thank you
are
very
you with
much.
us? Okay.
Yes,
Thank you.
I'm sharing my screen.
Yes, please.
Hello to everyone. First of all, I would like to thank you for this great organization. It's a great honor for me to take part in this ROP course. Let's start with the laser treatment. On this presentation, we are going to talk about which babies do we treat and when, which laser do we choose, how do we apply the treatment, and the postoperative follow-up and complications. The objectives of treatment are to downgrade the abnormal vascularization, to prevent retinal detachment, and to achieve anatomical success and functional success. The ideal therapeutic strategy should selectively control pathological neovascularization without affecting normal retinal vasculature during postnatal development, and it should support neural and vascular development of the retina. I think we should say that we don't have an ideal therapeutic option for ROP. The laser treatment can be used as a primary treatment, or it can be used for the recurrences after the anti-VEGF treatment, or it can be used as a combined therapy. The current indications of treatment for ROP are based on the early threshold ROP study, and we treat the babies with type 1 ROP, high-risk ROP. These are zone 1 ROP of any stage with plus disease, zone 1 stage 3 ROP without plus disease, and zone 2 stage 2 or 3 ROP with plus disease. For the cases with type 2 pre-threshold ROP, the frequent observation is more convenient because the 50 or 80% of them show spontaneous regression. The riskiest time for the progression to type 1 ROP at 33 to 36 gestational weeks. So we should follow up on the infants frequently at these weeks. For the cases with type 1 ROP, the rate of unfavorable results decreased significantly with earlier treatment, And the timing is crucial. Type 1 ROP cases should be treated within 72 hours. AP ROP cases should be treated within 24 to 48 hours or as soon as possible. When we decide to do a laser treatment, there are some ophthalmological risk factors that make it difficult to do laser treatment, such as thick and unclear cornea, rigid papilla, and vitreous cloudiness. These are more common with AP ROP patients, and in these cases, we should think about also the other treatment options. We have two lasers for ROP, diode laser or green laser. The major differences between them are listed here as follows. First of all, the diode laser is not absorbed by hemoglobin, so it's more usable in the presence of retinal or vitreous hemorrhages or more usable in the presence of tunica vasculosa lentis. And the cataract risk is less with diode laser. On the other hand, diode laser is absorbed by melanin, so it can cause deeper burns and more pain. and the visibility of spots is less with diode laser. Perioperative preparation is an important step. A detailed, informed consent is crucial. Perioperative pupil dilatation is of great importance for a successful laser application to the peripheric avascular retina. Another important thing is anesthesia. We can do laser treatment under general anesthesia, under sedation with fentanyl or remifentanil, or under local anesthesia, either subtenon or topical. There is a study which compares the anesthesia modalities, and according to this study, topical anesthesia was associated with more cardiorespiratory instability. And the topical anesthesia group, the ophthalmologist needed longer time, 12 to 16 minutes more, to complete the treatment. During the operation, the prevention of hypothermia and close monitoring of the babies for vital signs is of vital importance. We generally start with the worst eye, and we should rotate the eye instead of depression because of the ocular cardiac reflex. We use indirect laser delivery systems, and we use transpupillary laser by binocular indirect ophthalmoscopy. We want to complete laser treatment from the ridge to the ora serrata, not on the ridge. And we should be careful about the fovea, long posterior ciliary arteries at 3 and 9 positions, and ciliary body. The laser parameters, the power, duration, and interval should be adjusted. We should titrate the power for a wanted retinal effect to have moderate white spots, not opaque white spots. And do not forget the retina becomes thinner at the periphery, and you should titrate the power towards the periphery. The starting level for power for green laser can be 120 millivolts, and it can be 150 millivolts for diode laser. The duration is usually 150 to 200 milliseconds, and the interval 200 to 300 milliseconds. The distance between the spots should be more closer near the ridge, maybe nearly confluent, less than a quarter spot size apart. And the distance at the periphery can be more wider, a half or 1 spot size. The total number of spots varies according to the width of avascular region and the power of lens that we use. We generally use 28 to 30 diopters lens. We want to cover whole avascular area that needs laser, and the average count changes from case to case. In my practice, I want to have similar count of spots for right and left eye. I think it's more advantageous to prevent nisometropia, because we know that the more spots induce more myopia. There is an example here. This patient had zone 2 stage 3 ROP with aggressive fibrosis and interactions. Laser application to the posterior side of the ridge may be beneficial to prevent retinal detachment in these cases of aggressive fibrosis. In the past years, we used to use laser treatment for ROP cases, but in the present time, anti-VEGF treatments are an important option for them. When we decide to do a laser treatment for an ROP patient, two-step therapy seems more advantageous than single session. First, laser ablation from periphery up to flat neovascularization, and then after 5 to 7 days, and after the regression of flat neovascularization, laser ablation to the near avascular region can be applied. The success rate of laser treatment is generally high. Even for the patients with posterior zone 2 ROP cases, the success rate is over 90%, but the success rate is lower for zone 1 ROP patients. There's a patient here, and you can see here the regression of blast disease and the regression of flat neovascularization after a laser therapy. After the treatment, we use topical medication at least 5 to 7 days, sometimes 2 weeks. Topical steroids, cycloplegics, antibiotics, and sometimes non-steroidal anti-inflammatory drops can be used. And infants are followed closely for need of additional laser to any scope areas, regression of disease, generally it takes 1 to 2 weeks, progression risk to retinal detachment, and for the complications. It's important thing to don't forget the inadequate treatment is the most common problem for the ophthalmologist in training. And the most common region for skip areas are 6 and 12 positions. The signs of regression after the laser treatment are regression of glass disease, regression of neovascularizations, and regression of ridge height, as you see here. Sometimes we need retreatment. In the cases with persistence of glass disease, no regression of stage 3, or in the presence of tractions and retinal detachment, we need retreatment. First of all, additional laser for skip areas. If there is no skip area, additional laser to the posterior of the ridge can be applied. And so we use anti-VEGF treatment and vitreoretinal surgery. There are some perioperative and postoperative factors, risk factors for retinal detachment. Posterior zone 1 disease, periretinal hemorrhages before laser, glass disease of more than 2 quadrants, ridge of more than 6 clock hours, fibroproliferation after laser, no regression of glass disease, straightness of vascularization, cloudiness of vitreous hemorrhages, and condensation. Postoperative first control generally for early complications. These are so rare. These are anterior segment ischemia, hyphema, iris atrophy, intraocular pressure problems, posterior synechia, intravitreal hemorrhages, exudative retinal detachment, choroidal detachment, and hemorrhages. In this study, we have followed more than 10,000 infants, and we treated 556 infants with diode laser. And the complication rate was below 0.01%. An important complication is anterior segment ischemia. It can cause corneal opacity, cataract, hypotonia, and phthisis bulbi. And to avoid this complication, we should care about the long posterior ciliary arteries at 3 and 9 positions. Another postoperative complication is exudative retinal detachment and choroidal detachment. To avoid these complications, we should avoid the excessive laser treatment. Late complications are so rare, and myopia is the most common. In the recent years, there are some studies which investigate the post-laser findings. The most mentioned OCT findings for laser-treated patients are flattening of foveal depression and increased thickness of fovea. And the OCT angiography findings are small or absent foveal avascular zone and microvascular anomalies. There are lots of studies and some conflicting results, but some of them show that prematurity itself can lead to differences in the structure of fovea, and the gestational age is the most important predictor. There is a new study which compares the foveal thickness and foveal microvasculature in children with asymmetric ROP. One eye is treated with laser and the other eye shows spontaneous regression, and the authors found no difference on the OCT angiogram. But they found increased central foveal thickness in laser-treated eyes, and they said that the number of laser spots had an impact on parafoveal superficial capillary plexus density. Another important study which investigates the fluorescein angiographic findings in laser-treated eyes and bevacizumab-treated eyes in the patients at 4 years old, and they concluded that the fluorescein angiography has shown potentially serious and long-term ocular effects that are present more commonly after treatment with bevacizumab than after laser. For the last words, I can say that laser treatment still maintains its importance for the patients with type 1 ROP in zone 2. Thank you very much.
Thank you, Zuhal. It was a very, very nice overview. You are very experienced on that, and there are some questions also from attendees, but we will discuss it later. Now we will continue with Susana Teixeira from Lisbon. She is the ophthalmology consultant in Hospital Professor Dr. Fernando Fonseca in Lisbon. and she has quite a lot of experience on anti-VEGF treatment, and she will talk about anti-VEGF treatment for ROP. Susanna?
Hi, everybody. Let me tell you how happy I am to be here in this webinar among friends. And let me thank Şengül, my dear friend Şengül, for allowing me to speak about anti-VEGF therapy in ROP. I hope. Can I go on with? Okay, sorry. It has a delay, so it's quite heavy, my computer. We heard about the treatment of ROP, the treatment with laser, so it's an ablative treatment. For ROP, that is a proliferative disease linked to the high concentrations of VEGF inside the eye, we can use the ablative treatment to lower this VEGF, but we also can use angiomodulation. So it's a new treatment. It's also a baby treatment, if I can say that. And I will tell you a little bit of a story that also is my story. All the basic science and experiences with oxygen-induced retinopathy model show us how it worked, this proliferative disease, and how anti-VEGF drugs used to work in those models of ROP. So we were waiting, we that treat those babies, were waiting for some treatment that would help the eye, would help to control the ROP without have an ablative treatment of the eye. We know the cytokines, we know the physiopathology, and at 2004, we began to have a drug that was an anti-VEGF, and we began to use this anti-VEGF in the adult eyes. And we could see how it worked with the disappearance, the reversal of proliferation inside of the adult eyes. So it was just a little step to use it in ROP. ROP is a proliferative disease, and its acute phase is very limited in time. So it's not like diabetic retinopathy, it is a lifelong disease, the proliferation, no, it's limited in time. So we wanted a treatment that if we give it in the correct time, perhaps we could control this disease. This was the rationale, this was what we were hoping, and then the drug appeared. So we began to use anti-VEGF, bevacizumab, in Lisbon in 2006. And we did the injection. As you see, it's quite an easy treatment. The baby is under sedation, sometimes just with sugar. And usually there are no complications, no local complications. And so we began to do it as a complement to laser when the laser failed. And in 2009, as it was so good as a primary treatment. It was not just me, it was everybody all around the world that were dealing with babies that had to face ROP every day. Everybody began to use anti-VEGF in the treatment of ROP. So I published a paper, and everybody from India to China to Mexico, everybody was doing anti-VEGF because it was a promising, and it is a promising drug. But just in 2011, we had the first prospective controlled randomized study. It's the BEAT ROP that show us the superiority of intravitreal bevacizumab in relation in phase 2 laser therapy of ROP. And it has a 4% of recurrent disease facing the ROP treated with laser that had a 26% of recurrent disease, but it was most significant in zone 1, where 6% of babies had relapsed disease, comparing to 42% of babies that had laser for ROP. Of course, 42%, it's much higher than the ETROP that we had, that in zone 1, it was just 30%, but it's compelling the efficacy of this drug. Nowadays, we have other drugs that we can use also in the control of retinopathy of prematurity. All over the world, people is using ranibizumab. It's a little drug. The philosophy is a little drug has a more rapid washout from blood. So it must be more safe for such a tiny baby. But as it has a more rapid washout in the blood, also has a more rapid washout from the eye. So we have quite an amount rate of recurrences in most of the papers that we have. Last year, finally, we had presented and published a randomized open label randomized trial facing treatment with ranibizumab versus treatment with laser therapy in the eye. And this study showed that really it has a good success, ranibizumab in both concentrations, but most in 0.2 milligrams, although it has a high level of recurrent rate. So for treating the baby with ranibizumab, you must inject twice, and sometimes for 30%, you have to have an additional treatment for those heights. With this evidence, EMEA approved this drug in Europe. So in Europe, ranibizumab is already in label the retinopathy of prematurity treatment is already in the label of ranibizumab. But we also have other drugs that we can use. We have aflibercept that is ongoing and trial that it's named Firefly, and the trial will be Firefly and Firefly Next that will tell us the efficacy and rate of recurrence of aflibercept. And we also have combercept used all over the world. So now we have a lot of experience, or somehow some experience with this kind of drugs, and it's spread all over the world. I mean, anyone really can do this drug. So more than use this drug, I think it's very important to know how to use it, because every treatment has a good side and a bad side. So the use of anti-VEGF is a very potent treatment. So we must know really how to use it to avoid the complications. So I usually use it, and in Portugal and most of the centers that I know, we use it in type 1 ROP, in posterior ROP, in zone 1 ROP, posterior zone 2 ROP, and aggressive posterior ROP. Those are the best indications. I also use it in zone 2 when I cannot perform laser, because laser is a very nice treatment for zone 2. And usually I use it when the baby is so sick they cannot do a general anesthesia. What's important is when I shall not do it, because it's very, you can have a very aggressive answer to this kind of drugs if you don't use it properly. So I don't use it in very extensive proliferation, in extensive fibrotic changes along the ridge, so in a very advanced disease, because if I use anti-VEGF, I may have a huge contraction and a progressive retinal detachment, like in adults with in diabetic retinopathy. So I avoid always to use very late, don't stretch the indications of anti-VEGF therapy. Also in stage 4 and stage 5, if you inject, you will have a progressive retinal detachment most of the times. So you just inject in these cases if you really have an OR and you can do a vitrectomy if you have a retinal detachment. So it's very important not to stretch the indications of the treatment unless, and you can use it, anti-VEGF, before a surgery if you are in stage 4 to make the regression of the vascular disease, so you can make easier the surgery. You can use anti-VEGF, but not as a primary treatment without having OR where you can make the vitrectomy. Second, never use it in type 2 ROP. I mean, anti-VEGF therapy is a therapy for a proliferative disease. It's not a therapy for a not proliferative disease. If you use it before time, you just delay the disease. So you'll have again a proliferative disease, but delayed in time. So anti-VEGF is not a drug to prevent retinopathy of prematurity. So that's the two messages I think we must tell to people, and you must leave to people. And that's why sometimes you say, oh, I injected anti-VEGF and I had a huge retinal detachment. You have 3, 4, 5 papers about terrible retinal detachments after the injection of anti-VEGF, but perhaps it's because it was not properly injected, it was not properly treated, it was in a stage 4 or in a very extensive stage 3. Now, there is something different, and this kind of phenomenon exists, is very rare, it's described, it's a progressive fibrotic retinal detachment phenomenon that it's not linked with proliferative vascular disease, but with a fibrotic, non-vascular fibrotic disease. And I'm going to show you the example. This is a baby. A baby had 2 injections of anti-VEGF, and after 2 injections of anti-VEGF at 9 weeks of age, 9 months of age, he had a lot of popcorns all around all the retina. So I looked at that and said, my God, what's this? Popcorns, again, plus disease, so I'm going to inject. I injected a 3rd time and everything disappeared. 1 month later, I had this innocent fibrotic, I don't know how to classify this, but it was so innocent, so white, I decided to see. And 1 month later, I had a retina completely dragged to the optic disc. So it's a kind of phenomenon. It's very rare, but we must be very attentive of it. We must recognize it, because as soon as we see something like this, and it's very innocent, we must treat differently, or with surgery or with laser, but we must do something to avoid this stage, because this stage, even with surgery, it's very difficult to fix this retina. So that's the limits, I think, of the treatment. And now, how is it the treatment? I will show you my images, part of my experience. We presented several times this experience with the treatment of ROP. The first treatments that I had were combined treatment. What do I mean? I did laser, the disease progressed, and then we did injection of vaccine. And this is the first case. Someone asked me about the first case I presented in Lithuania. This is the first case we presented in Lithuania. And this is the baby. I had zone 1 ROP, did laser, fed laser, and this is the day of the injection. And this is 24 hours after the injection. So you see, tunica vasculosa lentis disappeared, plus disease disappeared. The disease, the proliferative disease was quite better, so it's a wow effect. It's very interesting because it's really a wow effect, and is during all the years that I still see the child, the disease is stable. There is no recurrent disease, and everything is very stable, except the high myopia that I induced with the treatment, laser treatment. That's for you, Odina. This is the baby that you sometimes see you see in Bascom Palmer, and of course you have the typical OCT with the internal layers in the eye. Now, primary treatment. We have the disease, we inject. Next day, we look at the baby and we have a little less plus disease. Look at the periphery, you still have proliferation. So it's not a wow effect like you have with the combined treatment, but 1 week later, you have very much less plus disease. The proliferation is regressing. 2 weeks later, it's very better. And 3 weeks later, you have the best result. I mean, you can have complete regression of the retinopathy, the proliferation, and usually no plus disease. That's the usual result of the treatments. So I saw you the bad cases, and now I show you how it usually works. Then in weeks, the retina began to be vascularized, and you see this almost two disease, and there is something in front where the vessels are growing to grow. So you see like a two disease, but it's not a ridge. I think it's the way the vessels grow and to the periphery. And finally, you have usually a complete vascularized retina to zone 3. Sometimes not all the zone 3, but to zone 3. This is the anatomic outcomes. Then you have the refractive outcomes, and we all know, and there are papers published about the difference, and they induced myopia by the laser treatment, and the almost normal emmetropization of the eye submitted to an anti-VEGF injection. That's my experience. In treatment in zone 1, I induce a high amount of myopia, but just with primary treatment, we have a nice emmetropization of the child. And let me enhance what the colleague before me said. We must never perform asymmetric. Even if you have a symmetric disease, you must never perform asymmetric treatments. If I do laser in zone 2+ and I want to do laser, I also must do laser in the other eye. This because we induce a high myopia in zone 1 disease. So in zone 1 disease, if you decide to do laser both eyes. If you decide to do in the anti-VEGF, you should do anti-VEGF in both eyes, but never asymmetric treatments. Now, it was very interesting because while the vessels grow to the periphery, in zone 1 babies, we could find some funny or some different characteristics of this vascularization. For a long time, you could see that the eyes of the child have some like engorgement. Sometimes we have shunts, abnormal vascularization, abnormal dichotomy in the periphery, even in completely vascularized retinas. This is better seen with angiography. So angiography is a wonderful tool to follow up these patients all the time. And you can see here shunts, here abnormal vascularization to posterior, and we still don't know if it has any impact with the function. What worries us, and that's a polemic issue, is the avascular peripheral retinas. So you can have all the retina completely vascularized in 6 months, but you can also have quite a few kids with avascular peripheral retinas. And that's the problem that is worrying much of our colleagues, and it's a problem that fractures the colleagues between those that are very worried with this avascular retina and those that think that it's natural. So you can see this is a baby with 7 months after postmenstrual age and has a huge avascular retina, but with no activity. But this one, you can see in the border, it's the same, but in the border, you have some kind of activity that can worry you. So here comes the problem. Do we treat or do we not treat these patients? And how do we treat these patients? And the fracture is that there are a group that think that this is really a preclude of a late relapse recurrent disease, and there are other groups that think that most of these diseases, these avascular areas, are natural because Sarah, I don't know how to say this now, also show the same alterations and the same avascular retina in eyes that never used anti-VEGF, but had a regressed posterior, but a regressed disease. So we never know really what to do. Do we really follow up these retinas and these avascular areas, or do we laser and stay quiet? Although I think we should not stay quiet ever, because sometimes this is linked with the fever, as we said. More than this avascular area, I think it's very important to know, to recognize the recurrence, and that we cannot miss. So recurrence, you have plus disease. Recurrence, you have the proliferative disease at the advancing edge, or you have a second form of presentation of recurrent disease that is always plus disease, and then you have the recurrence at the first site of ROP at the advancing edge. Whatever you see, if you recognize, you must look for recurrences, and as soon as you see them, you must treat them. So those are the message to people who is going to be on the field treating the babies. The second fracturant issue is safety. I mean, we know nobody has any illusion. If you put in a drug inside the eye, it will come outside the eye. Lower drug come easier, but also will have a washout. Huger drug will stay more time in the eye, but also will stay more time in the blood. And we really don't know, and that's our worry. We really don't know if it has this these drugs inside the blood, as the kid is developing, the kids, the brain, the lungs, so it's in an active developing time. If this even tiny amounts of anti-VEGF drug and lower anti-VEGF for a time period will be important or not. I believe that there will be no definite proof, because it's like our colleague from neonatology told, this is a multifactorial disease. So we cannot skirt in at all the factors and have a definitely proof that will tell you if how much lower level of anti-VEGF will be completely important for the neurodevelopment. I'll find you 10 papers that say yes, 10 papers that say no. Although I think it must be always a worry for us, because it's important. Those babies usually are golden babies, you know, parents want to have those babies. So we must try to provide, even if we don't really know what's the definitely proof of those complications, it must always be bared in our mind to know that we are making some treatments that can have this effect. That's why we are looking for better drug, better concentration, better time, combined new strategies. And I think, and I hope, I hope that we have more and more debate about this. And I think it must be a global, a world debate, because to have definitely some conclusion about the neurodevelopmental complications, we must have more than 2,800 patients to have some kind of real insight and real proof. So it must be a global worry, and somehow we must organize to answer these questions. The most I read and work with ROP, the most doubts I have, but I don't have a doubt. I think anti-VEGF is a very good tool. It has wonderful pros. Of course, it's very easy to do. It is available to everybody. There is no myopic shift. There is rapid regression of ROP, but there is another issue, that's the cons. And mainly two cons is the safety and really the long time follow-up that those kids ask from our work. But I know what I like most to see if I am facing a zone 1 ROP like this. It seems like an oxygen-induced ROP. So I'd like to have an eye like this, but more than have an eye like this, I would not like to have an eye like this oxygen-induced retinopathy. Thank you.
Thank you, Susanna. It was a real great review for anti-VEGFs, and you have many questions in the question and answer box. Please check it, and we will try to discuss some of them, but you can type the others if you can. And we will just pass to the next one. We will move on to experimental evidence supporting safe strategies of anti-VEGF in ROP, vaso and neuroprotective aspects. And this talk will be given by Mary Elizabeth Hartnett. She is a great person, I should say, and she is a distinguished professor in ophthalmology and visual sciences in University of Utah, Salt Lake, and she is presidential endowed chair in ophthalmology and visual sciences. She's director of pediatric retina with retinal medical and surgical service, adjunct professor of pediatrics and neurobiology and anatomy, and she has retinal angiogenesis laboratory in John Moran Eye Center, and she has approximately 200 publications in PubMed, and she is the chief editor of very well-known pediatric retina book. Thank you, Mary Elizabeth, coming to this webinar, accepting to talk here, and it's your turn.
Thank you very much. Can you hear me, Shango?
Yes, we can hear and we can see the PowerPoint.
Okay, good. And thank you for this very kind invitation and for the opportunity to speak to you all today. I'm going to kind of shift into my role. I'm a clinician scientist, and I'll be talking to you though about some of the work that we've done in our laboratory. And so let's see. All right. I have no relevant commercial disclosures. I am having a little trouble getting my slides to advance. Let's see, there we go. So we found that inhibiting an angiogenic pathway not only reduced neovascular growth into the vitreous, but it also very surprisingly caused angiogenesis and facilitated normal retinal vascular development as well. And both of these are important when we're thinking about treating retinopathy of prematurity. So using experimental models, we delivered gene therapy by subretinal injections and showed that regulation of signaling through VEGF receptor 2 specifically in retinal endothelial cells ordered the endothelial cell division so they formed vessels that extended into the peripheral retina instead of on top of one another as neovascular growth into the vitreous. And we can see this in the following animation, in which the cleavage planes of the endothelial cells are disordered, and the direction of vessel growth, which is perpendicular to a line drawn between the cleavage plane of the mitotic apparatus, leads to growth into the vitreous. Now, on the right, you'll notice that ordered growth extends vessels toward the ora serrata. And this provides one mechanism how anti-VEGF specifically treats the developmental angiogenic disease retinopathy of prematurity and still facilitates normal angiogenesis. And this is unlike what occurs in most adult angiogenic diseases. Now, we know subretinal gene therapy is infeasible in infants' eyes. So I will discuss and describe our experimental approaches that translate into what occurs when intravitreal anti-VEGF is used to remove too much vitreous VEGF. But I'll focus on some of our work and how this may affect the neural retina in the infant eye. So as we've heard, anti-VEGF has allowed great strides in ROP management. Whereas laser was effective in treating intravitreal neovascular growth, it destroyed the peripheral retina and may not have permitted additional developmental angiogenesis. Anti-VEGF both inhibits neovascularization into the vitreous and allows vascularization of the previously peripheral avascular retina. But as anti-VEGF was being adopted throughout the world, and we've heard this by others, there were concerns recognized and reported about later recurrence of ROP, neurocognitive deficits, and potential adverse effects on developing organs like the kidney and lung in the premature infant from anti-VEGF that leaked from the eye into the bloodstream. So for these reasons, we continued our studies into the role of VEGF on the newly developed retinal vasculature and developing neural retina. We wanted to use the most representative model of human ROP and therefore chose the rat model of oxygen-induced retinopathy, which has phases that represent human ROP today, including phase 1 of compromised physiologic retinal vascularity, seen here, and this is probably due to oxygen stresses, as well as a delay in physiologic retinal vascular development. And then this is followed by phase 2, tortuosity and vasoproliferation as intravitreal or extraretinal neovascularization, which is similar to stage 3 ROP. And these outcomes can be measured and analyzed to address our experimental questions and still relate to human ROP. So in our early studies, there was very little understanding of why blood vessels grew into the vitreous in ROP. And we hypothesized that a mismatch of angiogenic factors to inhibitors, and the inhibitor we chose specifically was pigment epithelial derived factor because it was increasing hyperoxia. And we thought that this mismatch was associated with a lower angiogenic drive in phase 1, where you have avascular retina, and a higher angiogenic drive in phase 2. However, we surprisingly found that the angiogenic drive in the OIR model compared to room air pups of the same developmental ages was increased in both phase 1 and phase 2. So we then performed dose response experiments using neutralizing antibodies to VEGF and found reduced intravitreal neovascularization. We thought that inhibiting an angiogenic factor would interfere with normal intraretinal vascularization, but we did not find that as there was no increase in peripheral avascular retina. But we did find that there was a later recurrent intravitreal neovascular growth and associated with increased retinal VEGF. So we then became interested in assessing the effect of anti-VEGF dose on reactivation of ROP, because we recognize when trying to deliver very small volumes and in very dilute concentrations that there can be quite a chance for error, especially since ROP affects infants of all different sizes and developmental maturity. So we developed an indirect approach to reduce vitreous VEGF. So instead of removing VEGF from the vitreous with an intravitreal antibody, we targeted the cells that we found overproduced VEGF using a lentiviral vector system in which Mueller cell VEGF was knocked down by targeting VEGF mRNA with short hairpin RNAs against either the full-length VEGF-A or VEGF-164, which is the analog to human VEGF-165. And we compared this to shRNAs to luciferase as control. And these were delivered by subretinal injection. The VEGF shRNAs would reduce the expression and therefore secretion of VEGF by Mueller cells into the vitreous. And so this was an indirect approach. And here we see that both the experimental, we see here, and the control shRNAs were transduced by retinal Mueller cells. And we can tell that by the green fluorescent protein tagged on retinal contact imaging. The VEGF-A shRNA reduced retinal VEGF to the level of room air raised pups, and we see that here. So here's the VEGF-A shRNA, and this is room air raised pups. We defined the lentiviral delivered VEGF-A shRNA as the optimal anti-VEGF dose. So using this method, we found that intravitreal neovascularization was reduced and there wasn't recurrence even out to day 32. And physiologic retinal vascular development was partially extended without significant increase in peripheral vascular retina. So we found similar effects by knocking down VEGF-164 and found no recurrence of disease even out to postnatal day 32. This suggested that dose was important for reactivation to occur since a lentivector approach did not lead to reactivation, but as you'll remember in previous slides, that using the intravitreal antibodies to VEGF did. So we performed another study and we wanted to know why this might be. And we compared the intravitreal anti-VEGF dose to its control, which was IgG, and against the gene therapy targeting VEGF-A in Mueller cells to its control. And the outcomes were the extended physiologic retinal vascular development measured as area of peripheral avascular retina, so what I showed previously, but also we measured physiologic vascularity of the already developed vessels by looking at fluorescence in the vascular retina. There were no differences between groups as to the vascular coverage or the physiologic retinal vascular development, but the intravitreal anti-VEGF dose that reduced intravitreal neovascularization significantly reduced capillary density. Now, this suggests that too high or the wrong dose of anti-VEGF may damage oxygen-stressed, newly developed retinal capillaries and could be part of the reason to leading to recurrent or reactivation of ROP. Thus, preserving physiologic vascularity appears important to reduce recurrent intravitreal neovascularization or reactivation of ROP. We then asked if an optimal dose of anti-VEGF using the shRNA to VEGF-A and Mueller cells would be detrimental to the retina. And here we used the Mueller cell-specific knockdown of VEGF-A and compared it to the luciferase control or to the VEGF-164 shRNA. We looked at thickness of the retina, function by ERG, and the expression of neuroprotective factors, which we believe represent a compensatory response. The Mueller cell knockdown of VEGF-A, but not VEGF-164, thinned the outer nuclear layer, but neither reduced ERG function in A wave or in B wave. And we explored if this was related to the expression of protective factors to glia or neurons, and found several neuroprotective factors shown here, such as here is erythropoietin in the VEGF-A shRNA, brain-derived neurotrophic factor, neurotrophin-3, and we also found, not shown here, glial-derived neurotrophic factor and nerve growth factor had increased expression. So it appeared that knockdown of the full-length VEGF-A stimulated compensatory neuroprotective factors, whereas secreted VEGF forms that could still be secreted when only the VEGF-164 splice variant was knocked down, gained access to the retina. So we also determined if the knockdown of VEGF-164 affected the number of ganglion cells compared to the knockdown of VEGF-A. And whereas knockdown of VEGF-A reduced the number of cells in the ganglion cell layer, knockdown of VEGF-164 did not. We interpret these findings that VEGF is vasoprotective and neuroprotective in oxygen stresses representative of human ROP, but that an appropriate dose of anti-VEGF shown experimentally by interfering with Mueller cell expression of VEGF or VEGF-164 and thus secretion into the vitreous might be feasible and reduce vascular reactivation. Furthermore, allowing some secreted VEGF forms by only knocking down VEGF-164 did not thin the retina or cause compensatory increase in neuroprotective factors. And these findings support the idea that certain doses or formulations of anti-VEGF may be effective and safe for the neuroretina. Rainbow reported efficacy and safety with ranibizumab, but retreatments were needed. Aflibercept is being tested in butterfly and firefly and other studies, and the Pediatric Eye Disease Investigative Group of the National Eye Institute will now be testing a low-dose bevacizumab 2 laser and will also be assessing neural findings as secondary outcome. And with that, I'd like to thank you for your attention. I'd like to acknowledge my funding sources and my laboratory members who perform this work. And I think we're probably ready to address questions you may have. Thank you.
Thank you, Amy. It was really very interesting and quite a lot of work. I know you're doing these experiments for a long time, and we have some questions, and we will moderate the discussion together, Amy. But the first questions, I want to give the first questions to you from the audience. There's a question is asking, is there any research that has investigated the amount of VEGF receptors of the retina before and after IV anti-VEGF injection?
Okay, let me make sure I heard that right. So is there any research that looked at the amount of VEGF in the vitreous after, is that what you said, after anti-VEGF was delivered?
Not the amount of VEGF, but VEGF receptors.
Oh,
before
okay.
and after. Yeah.
Yes. So after anti-VEGF, there's been certainly no human studies that has shown that. But if the idea does VEGF regulate the number of VEGF receptors? There were studies in cells that show that when you have increased ligand expression of VEGF, you can get an increase in the receptors. So the receptors are complicated because the way that they signal or trigger signaling, they have to be taken into the cell, and then they are phosphorylated at tyrosine residues, specific ones.
Okay, and the same person asked again, would recurrence result from a reflex increase of receptors in time?
Would recurrence of a reactivation occur? Would there be increase in receptors? And I don't know that we know that.
Okay.
There might be, but I don't know. Yes.
Okay, thank you. And there are some other questions for the other talks. For example, what's the technique for Susanna? What's the technique of injection in babies? Because they are small eyes, to avoid from lens touch. What do you do? What are your tips for that? Can you unmute yourself, please? Unmute.
Mute.
Yes,
Okay.
now we can hear.
Well, that's an important question because we want to treat without harm. And to make cataract, it's the worst thing you can do to such a tiny baby. So usually I'm performing the injection. I have a 30 gauge needle. Some people has a lower gauge needle. Usually I perform it between 1 and 1.5 millimeters from the limbus, depending on the gestational age, postmenstrual age, you know. If it is a tiny baby, I make it more close, although I have a huge lens, although I have a huge lens, I do it at 1 millimeter. If the baby is a bit little, 36, 38 weeks of age, I do it 1.5 millimeters of age, and I point it to the optic nerve, not to the lens, so to the optic nerve, and I don't put all the syringe, the needle inside, just 1/3 of the needle inside. So I try to avoid the best I can to touch the lens.
Okay. And which anti-VEGF do you use?
What?
Which anti-VEGF do you prefer? Actually, this is asked
I'm
to all the panelists.
Yeah, the one I prefer. Well, like everything, if you speak with something, if you use a technique, if you use a drug that you know for so long, like bevacizumab, I am comfortable to use bevacizumab. Of course, I'm open to everything because I know there are, for sure, neurodevelopmental issues. But I know exactly how it works. I know exactly how much recurrent disease I will have, in what kind of diseases I will have. So I am comfortable with bevacizumab. We are using a lower dose to avoid the kind of neurodevelopmental complications. But I think we can open the treatment to other drugs. Why not? But we must make the balance between efficacy and safety.
And also, one more question. Is there any place of anti-VEGF for anterior segment ischemia? For the treatment of anterior segment ischemia?
I never use it because I perform much.
Anybody has experience on that?
But I never had anterior ischemia. But theoretically, yes. And the first paper ever of injection of anti-VEGF in the eye was from an Indian group, I don't know the name of the Indian group, and it was in an anterior segment ischemia of the eye after laser with good results. So this was the first paper about the use of anti-VEGF in an eye of a premature baby.
Okay, thank you. And another question from the attendees to all the panelists. He has 1.1-year-old baby now who had anti-VEGF injection for ROP, and now he has persistent tortuosity of the vessels and persistent peripheral avascular zone. Together with 360, he says demarcation line, probably that's rich area, and he says when to stop the follow-ups and what to do for such a case. So can anybody want to ask this question? Amy?
I couldn't understand it. Sorry.
Sorry, you couldn't hear
understand it? What was the question?
Should I repeat it?
Yes.
It is
okay. So he has a baby who had anti-VEGF for ROP treatment, and now the baby is 1.5 years old, and the baby still has vascular tortuosity, not plus, but tortuosity, and peripheral avascular, persistent avascular areas, together with, I think that is rich area. He says demarcation, 360 demarcation line. Probably that means some rich elevation. So he asks when to stop follow-up and what to do, do you treat or not?
Well, I would laser this baby, right?
Me
so
too.
on the one hand, the chance at 1.5 years it's going to reactivate is small. On the other hand, you can never be sure because you have persistent avascular retina, so on and so forth. So to set the baby free, set the family free, and set the doctor free, laser would bring this disease to a treatment terminus, if you would. And frankly, I think it's past time for that.
Thank you, Tony. I agree with you. Any other?
I would probably also laser, but one thing to remember too is that sometimes the tortuosity can be associated with things like pulmonary hypertension or cardiac disease as well. So you can be in that situation where you treat them and it doesn't seem to go away, but it may not be related to ROP.
Yeah, and worth saying, since you're talking about it, I mean, that dilation regresses nicely, but tortuosity does not always fully regress. So it may just be this child is going to remain tortuous forever. But with a ridge that has structure to it, as Sengul described, and persistent avascular retina, the safest course for this child is going to be laser to bring the disease to an endpoint.
Thank you, Tony. And Zohar, I have a question for you. What are your tips and tricks, just quickly, for the beginners to do laser for ROP, to prevent meiosis during lasering and all those things? Just quick tips, please.
Okay. First of all, we should care about the fovea, and the 3 and 9 positions is important for the prevention of the anterior segment ischemia. And also we should care about the ciliary body, because the immaturity of the pars plana, it's near the oral serrata, and we should think about the power of the power and lens parameters, and we should titrate the power towards the periphery, because the retina becomes thinner at the periphery.
Okay, and what do you do for avoiding meiosis during the laser?
Actually, it can be a problem for the ophthalmologist and trainee because of the long duration of the laser treatment. And maybe I think a drop of cycloplegic we add, or sometimes mitrin and cycloplegic we can use.
And avoidance of too much depression, I guess, is also important for that.
Of course. Okay. Avoid too much depression to the same eye. Maybe we should complete the temporal side of the one eye and the nasal side of the other eye on the same position for the ophthalmologist, and then the other side of the other eyes, temporal and nasal, we can laser.
Okay, thank you. And there are many questions considering the follow-up after anti-VEGF treatment. How long do you follow the cases after anti-VEGF treatment? And they ask what's the intervals when the baby gets, bigger. So because it's really difficult to examine the peripheral retina in bigger babies when they become 1 year, 2 years. So do you wait for those peripheral avascular areas to vascularize themselves, or you leave it alone if you don't see any vascular activity? So what's your preference? Let's start from Capone. Tony.
We follow children out until 50 weeks, and if they have persistent avascular retina, we will bring them to laser. And now persistent avascular retina means generally more than 2 disc diameters of avascularity to the periphery. We laser to bring them to.
When do you laser?
After 50 weeks of age. If at 50 weeks of age or older, they have persistent avascular retina more than 2 disc diameters from the oris aorta, we laser them.
Thank you. Amy?
Yeah, so we kind of follow the AAO, AAP, and we try to go out to 60 weeks if possible. And then most of the time we laser these babies. They get too hard to examine, and I'm afraid I'll miss something when they do come in for follow-up.
Okay, and Susanna?
Well, I'm a little bit different. Most of the babies I used to treat, the retina, the avascular areas don't worry me. So what I do is I see them each 2 weeks until the disease disappears, the retina is vascularized, and then yearly. Those that have avascular areas, I follow them. If I see any kind of activity, I may vascularize the children, and I understand that sometimes it's very difficult to ask the parents to come so many times. But when I ask them if they want to be laser or if they want to be followed, they want to be followed. So those they want to be followed, so I follow them. My problem is always the different eye, the eye that reacts differently. I may have a fever and a recurrent disease. So what do we usually do? In those patients, we do angiography. So I follow them with angiography, and I have children 10 years of age with avascular areas. We regress the disease, and you can see the vessels have some kind of not activity, but like in adults, you have regressed proliferative disease, and you have in the angiography signs that they are neovessels. But they are 10 years of age. They don't have relapse disease. So I just act when I have really a relapse disease. But it's true. We need to see them. We need to make angiography. From sometimes on, we must make general anesthesia to follow those children. But I learn a lot to understand those avascular areas as I do this. So
thank you.
We must always balance.
And another question is, does persistence of hyaloid vasculature have a role in progression, especially proliferation over the optic disc? And do you inject both eyes simultaneously or sequentially? So anybody to answer the question? Could you get the question?
If we inject both eyes at the same time, or?
Yes, at the same time or sequentially?
If they have disease, I inject them at the same time.
Okay. And Nina, do you have?
Yes, always at the same time. Yes.
And do you think the persistence of hyaloid vasculature have a role in progression of the disease in ROP? Tunica vasculosa lentis.
When you see the persistent tunica vasculosa that just doesn't go away, it's because it's been stimulated by VEGF. So it lingers in those very aggressive, eyes. Yes.
And you see, if you make the screening, you see there is a time you have no tunica vasculosa lentis. And then you have the disease and again have the tunica vasculosa lentis, because at that time you have VEGF. So it's not a plus disease, but tells you how much VEGF is in the posterior segment.
Amy, you have any question?
Yeah, I do. Actually, I was wondering, I guess this is for Dr. Tune Zuhal. So I was wondering in anterior segment ischemia, if you saw that more commonly after diode or green laser. Do you see it one versus the other more?
We only see one patient.
Good.
Not so common.
Emmy, I can answer that because I did a retrospective review on ischemia a while ago, and we saw it more coming from the community from argon laser. And always the people who were lasering were just the first year out of training.
So I think Nina makes a couple of interesting points. So we also reviewed it when I was down at Emory, and you see it with green and red, and we did not see any difference in terms of wavelength. So so the implication to me, Nina, when you say that, is that people are treating heavily, and the kids that we saw were also the most. We seemed to see anterior segment ischemia in the exceptionally darkly pigmented kids. So all of that speaks to over-treatment, which I think, our findings and your findings resonate that way. And so, intense white burns that are sort of completely contiguous over 360 degrees are more likely to have, deep vascular complications.
And what do you do for treatment? Do you have any suggestion for such eyes?
Well, they're challenging eyes. I think anterior segment ischemia, first of all, is not an all or nothing phenomenon. We've seen mild cases where they'll get late, not the acute exudative detachment that you see sometimes after a fresh laser, but late exudative detachments at 2, 3, 4 weeks after. So that's usually a mild case, and with hypotony. And they will sometimes spontaneously resolve. If you get the full package where the eyes don't continue to grow, they develop cataract, they're hypotenuse. We've managed those eyes with lensectomy and silicone oil installation, but I will be 100% candid. I think that's an act of surgical desperation.
Yeah, I totally agree. Yeah.
I always when people...
I also use, I will treat them for a fair amount of time with steroids and cycloplegics before I do lensectomy as well.
Agree. I think intense steroids are probably the best. If you get them early enough, is the best thing you can do. Yeah.
I always think that when you treat, we don't do that anymore, but we used to treat, ROP that was very anterior, or that you're going to give a lot of laser, or you don't have enough pupillary dilation that you might get some absorption from the ciliary body when you're depressing, and the ciliary body is in the view of the laser beam. I think it's a great idea to pre-medicate those with steroids instead of waiting for the complications of having given so much laser, and that really works well.
Kind of prophylactic treatment.
Sengul, can I ask Emmy a question, please?
Yes, please.
Emmy, first of all, great work. You're absolutely the tip of the spear for all of us on the laboratory, study of ROP, particularly as regards VEGF. One of the things I take from your work is a question. I almost wonder if your work suggests that Macugen wouldn't be the best drug. And then how do you, what would you say to us about your work in the context of Jerry Luddy's work in the dog that demonstrated, differential effect of dosing of aflibercept with regard to inhibiting all vascularization versus inhibiting pathologic vascularization and allowing normal angiogenesis?
No, Tony, thank you for asking that. First of all, so I don't think Macugen would be the drug based on the clinical experience that I believe you and your group presented. But we have to remember it's an aptamer, and I don't think we know exactly how it works, like which residue of the VEGF receptor to its targeting. So it can bind VEGF and prevent it from the receptor, but if it still allows VEGF to trigger signaling through the residue and the tyrosine, then you could still get an effect. So it may not be a fully effective drug like using an antibody, which binds the ligand and sort of prevents it from a neutralizing antibody, binds the ligand and prevents it from triggering the receptor. And then as far as, I think Jerry Luddy's work in the dog was great. And I think we were able to see a similar effect in the rat. So in other words, I think the difference might be the size of the eye. So we did dose response and were able to show a reduction in the neovascularization in the vitreous with, but we, later on we got recurrent disease. But when we use that indirect approach to reduce the amount of expressed VEGF, so it was a more refined way to inhibit VEGF, we saw that we did get vascularization to the periphery. And I think it's through receptor 2, because we also use gene therapy where we knock down VEGF receptor 2 only in retinal endothelial cells, and we got extension. So Jerry used the trap, but it's basically trapping the ligand and maybe placental growth factor as well.
Right.
Did I get your question?
You did perfectly.
Thank you.
And one last topic for discussion, then we will go to the next section. Last question is about what do you do if a persistent vascular activity is still there in spite of laser and anti-VEGF? Do you do anti-VEGF re-injection or not, and what are your criteria? So can I have very quick responses from each of you? Who wants to start? Re-injection criteria.
So if you have a relapse disease, if you have a recurrent disease, you can use laser again. You can use laser, or you can inject again. So I don't see.
So when to re-inject or when to laser? After anti-VEGF injection, when you see reactivation, do you just re-inject or just go with laser?
So I guess it depends for me on whether there's fibrosis. So if it starts to look like you're getting progressive fibrosis, I think in those cases, I might consider surgery.
Okay, good. Tony?
Yeah, it's not a super simple question, but I'll try to answer simply. If the child's already been lasered, I would check for skip areas and add laser. If the child has been fully lasered, I would consider re-injection. But in the back of my mind is these children will sometimes get high loidal contraction, and that will give you persistent vascular activity. And as Emmy suggested, that would require a laser. That's my short answer.
Okay, very great. Nina? Thank you.
I will go kind of like Tony, but a little different. I will definitely look for skip areas. I always like to relaser myself if somebody else did the laser, but I will inject Avastin at the time of my relaser without fear.
Okay. And Zuhal, anything to add?
I generally prefer laser, but if the vascular component of the disease is more prevalent, and then I think the anti-VEGF treatment is more appropriate. And the fibrotic component is more prevalent to laser.
Okay, thank you. Great discussion. I'd like to thank you all, Emmy, Susanna, Zuhal, for the great talks and discussion. So we will pass to the next session. And the next session will start with Dr. Tony Capone, and he will talk about management of stage 4 and 5 ROP cases, surgical management. He is the co-president and partner of Associated Retinal Consultants in Michigan, and he is professor in ophthalmology in Auckland University, William Beaumont Hospital, School of Medicine in Michigan, USA. He has almost 190 publications in PubMed, and he is one of the editors of Pediatric Retina book. And he has trained many ophthalmologists from all over the world, including me, in pediatric retina. And I have learned the philosophy of pediatric retina from him. I would like to thank you for, everything he has given to me. I'm grateful to him and Dr. Tracy. And thank you for sharing your knowledge and for being with us here. Please continue. You can start your talk.
Thank you, Sengul. I'm going to share my screen. Thank you for the very kind intro. Let's see, I think this will do it. And let me just go to exclusively presentation. One moment, please. All right. So again, thank you, Sengul, for the kind invitation. It's great to be with this. I love the pediatric retina community. It's just a wonderful collection of very smart and very talented, very kind-hearted people. Sengul asked me to summarize the management of the cicatricial phases of ROP, and these are the three general categories that I'll speak to today. There will be a lot of images, and I do that on purpose because I think it's very important to sort of increase our visual vocabulary, if you will. The more pictures you see of ROP, particularly its unusual iterations, the better it is. So let's first start talking about the goals. And the goals of surgery for advanced ROP vary with the severity of the detachment, and perhaps that seems self-evident, but for the milder levels of disease, we hope for as normal vision as possible, and clearly for the more severe levels of disease, as in the image on your right, we're hoping to rescue really any vision that we can, as children with the degree of fibrosis you see to the right often end up with light perception only during their childhood, and many evolve to no light perception in adolescence. So for stage 4A, we'd like to preserve the anatomic integrity of the eye, meaning preserve the lens, ideally fully reattach the retina, maintain normal macular anatomy, and we aspire to central fixation vision. Here is a child who has an extramacular detachment, had arrived actually not having had laser. As you can see past the detachment, there's no laser, so there's contraction, elevation, hemorrhage. And here's the child post-treatment with a resolution of the detachment following a vitrectomy and laser. For stage 4B, and now the macula is included by definition within the detachment, our goal is to minimize retinal distortion, maximize posterior pole attachment, and we'll take as good vision as we can get, but we discuss with the parents that our hope is ambulatory or form vision, and kind of an unspoken goal, which all of us who take care of these children are aware of, is to prevent progression to stage 5 disease. And so here's a fairly advanced stage 4B in your, on your left. The red reflex you see up above is the area of retina that's attached. And here's the post-op image of this child. And so while clearly the macula is not normal, it's dragged, and there's some lipid and fibrosis still apparent, the visual outcome and prognosis for the image on the right is clearly far better than that of the image on the left. Stage 5 is a rescue mission. We hope to maximize reattachment, and by that we mean any reattachment. And we hope to have sustained light perception vision, and if we're fortunate, form better than light perception vision, form, motion, or better. So here's an example of a young Ukrainian child who came some years ago, and she had bilaterally symmetrical disease. Here's just her one eye with a pre-op image, and this is what she looked like at 1 week post-op. And this underscores the point that these eyes take a while before they resolve. They have a lot of subretinal blood and lipid commonly. Here's the 3-month image, and clearly things are starting to look much better. This child has very clearly has a visual life. Her parents have sent me videos. She interacts in her environment nicely, and so on and so forth. So a very different future for the child with an image on the right than the image on the left. Let's talk a little bit about anatomy. The kind of core feature of ROP generally is that there are multiple tractional vectors in these eyes, and the cartoon to the right speaks to that. There are tractional vectors that are intrinsic to the retina, and I'll discuss those briefly, and the ones that are amenable to surgery are the ones that are transvitreal. The structure of these eyes can be highly variable because of all of these different tractional vectors. Every color is a different vector, and depending on which one predominates, the anatomy of the detachment will differ. So the more you know about how it's broken, the better you'll be able to fix it. This is an image that shows a combined tractional vector. I'm going to talk about it while the cartoon plays to the right. And the circumferential traction is what gives you the radial fold, and the antero-posterior traction from the ridge to the lens, it was what lifts the retina. So in the cartoon to the right, you can see early on this sort of structural change that starts to span the vitreous, and as the detachment gets more mature, the structural components can really be broken down into fairly stereotypic pattern. Now, not every eye has every component, but every eye has one or more of these components. And I'll go through right now just giving you some images to demonstrate these vectors. So the one that is not amenable to surgery ensues as a consequence of contraction of the stage 3 ridge, and that is circumferential contraction, produces radial folds, as you see here. And this is not a surgical tractional vector unless, from a vitrectomy perspective, you can mitigate it to some degree with a buccal and sometimes a radial element. But to truly address this vector, you'd have to excise it, and to excise it, you do retinotomy and retinectomy, and we don't do that for ROP. So this is another diagram which tries to depict the multiple vectors. The other one was sort of a schematic cartoon, and this one shows the proliferation from the ridge towards the eye wall, the ciliary body, the lens, across the mouth of the detachment from one edge of proliferation to the other, as well as the various stalk configurations. The first one we'll talk about runs from the ridge back to the eye wall, and that's 1A. The surgical image to your right, the vitrector has entered that sheet, and so just above the vitrector, the sheet has been interrupted, and below it is the path that the vitrector will continue to take to interrupt this vector. It's usually not this opaque, but it is important in keeping the retina flatly detached after vitrectomy. This is the vector that runs from the ridge up to the ciliary body, and this is the one that's responsible for the antero-posterior displacement of the detachment. As this contracts, it lifts the retina anteriorly and towards the periphery, and that is typically complemented by this other vector that runs from the ridge to the lens that provides more of the antero-posterior elevation of the retina. So these three vectors are very important for getting the retina to sit back. And then there's what we call the drum head. Across the mouth of a funnel-shaped attachment, you'll often see an opaque sheet as well. And this is important for relaxation to allow the retina to flatten laterally. Lastly, the stalk, and the configuration of the stalk is predicated on how old the child was at birth in terms of postmenstrual age. The most primitive stalk, if you will, runs from the optic nerve flat along the retina to the stage 3 ridge. Here you see APROP, flat stage 3, and the stalk isn't really apparent until you dissect it. And when you dissect it, you'll see it's got a very, very small stalk. So this is seen in very posterior eyes. In more mature eyes, you'll see the stalk run this 3B from the disc towards the ridge transvitreally, and then in more mature eyes still from the ridge towards the drum head, as you can see in this picture here. As to the timing of surgery, ROP, obviously, as everyone has articulated today, follows a very sort of stereotypic course, and we generally do our treatment at approximately 36 weeks of age, plus or minus a couple of weeks, depending on the postmenstrual age at birth. Detachments typically will occur between 38 and 42 weeks for stage 4, and then progress to stage 5 over the subsequent weeks. In terms of timing of surgery, as you'll see in the upper right-hand corner, VEGF starts to decline, TGF-beta increases, the proliferation on the surface of the retina gets less vascular. So the timing of surgery is related to some degree to stage and some degree to vascular activity. For stage 4A, we will operate on them at any level of vascular activity because all we are interested in is transvitreal vectors. So we're not touching vessels, we're not peeling scar tissue. So if there are active vessels, it doesn't really impact on the surgery because one will not get bleeding. Conversely, for stages 4B and 5, we're peeling fibrovascular membranes off the surface of the retina. That requires a vascularly quiet eye. These children are typically not operated on until 48 to 52 weeks post-menstrual age. If you look at the curve of sort of visual potential at 4 years of age predicated on the child's birth history, it's pretty easy to see that there's an inflection point at stage 4A. And that's really the last opportunity to preserve high quality vision. So prevention is best for everything. Prevention from getting ROP, prevention from stage 3 ROP progressing to stage 4, and again, prevention from stage 4 progressing to stage 5. An interesting question that comes up is when is it that a child is too old to operate on? And certainly things go best if the child is operated on early for a variety of reasons. Obviously, the time course of visual development from a central level being first and foremost. However, it is possible to have a meaningful improvement in vision even in children who are operated on later. And I would say particularly if they have an open funnel configuration. So we don't use age as a strict criterion, but it's evaluated in the context of other aspects, the configuration of the funnel and the overall status of the child with regard to how cognitively intact or impaired the child is. The other common question is, well, when will we know how well my child will see? And again, on the work out of Dr. Hirose's equipe, if these individual values are on the left, if you sum them on the right, a normal child's course of visual development is in the black circles, and you can see that the children who've been operated on for ROP detachments, the curve parallels but never meets the black circles. But note also that visual development tends to peak at around 36 to 48 months of age. So generally by age 3 or 4, we'll have a good idea of what that child's lifetime visual potential will be. As with normally sighted children, there will be some improvement between 4 and say 10, but by and large, you know what broad strokes category the child will be in by 4 years of age. In terms of results, interestingly, the only prospective randomized trial that has data on surgery is the ETROP, and those data are not very encouraging. Of the children that were operated upon in ETROP, only 28% had a successful anatomic outcome, and only a small fraction of them, about 1 out of 5, had a favorable visual outcome. However, when you compare that to centers that are dedicated to the care, surgical care of children, there's a pretty stark contrast, with 80 to 90% of children having a good anatomic outcome, and respectable Snellen acuity has been seen in the children who've been followed longitudinally. So it begs the obvious question, why the difference? And the answer is that ETROP was a randomized and prospective clinical trial, but not for surgery for ROP, for the timing of laser. There was no standardized protocol in terms of surgical management, in terms of timing, what procedure would be performed, nor was it uniformly performed at dedicated centers. So I think clearly we learned from this is that A, the children can do well with surgery, and B, they need to be at a center that has an interest in this kind of work. And this is not the only study to have this kind of outcome. This was seen also in the silicone oil study, where there was a broad variability in success in the management of PVR, depending on whether the center was a dedicated PVR center. It's interesting to look at the literature for stage 4B and 5 ROP because it's got a fairly broad range in terms of the numbers of children that are included, the inclusion criteria, whether 4B alone or 5 is looked at. I thought it would be useful to briefly try to summarize and give a little order to that body of data. And here are some of the largest studies done to date on this group of patients. And I'll begin by talking about follow-up ranges from 6 months to almost 9 years in this cohort of papers. Again, some do only 4B and some do only 5. The percentage of eyes with attachment varies from 90% to 13%, again, depending on the center and the severity of detachment studied. The two longest or two largest studies for 4B and 5 combined, with the longest data that are single surgeon, are those out of our center with Dr. Tracy back almost 20 years ago, and the series of eyes that Dr. Gusan and I collected more recently. And interestingly, if you look at this, the success rate for 4B and 5 hasn't changed on the one hand in 20 years. However, if you look at the NLP incidence, you can see that we are achieving the same anatomic results, but that with a significantly safer procedure, as the number of children with severe vision loss, either because of the surgery not achieving adequate reattachment to make a meaningful impact, or because of complications of surgery, we're clearly in a more favorable environment. Factors impacting on outcome relate to both timing of surgery and anatomy. Again, the work of Dr. Hirose and colleagues, and long story short, if you look at the graph to the right, the more open the funnel, the higher the success rate. And so when we give our numbers for success as being 50% for all comers in terms of anatomic success, it includes all of these different funnel classes. And in terms of vision, again, while it's statistically speaking, these data were not significantly different, the numbers are fairly small. And you can see, however, that there is pretty clear clustering in the graph, so that open generally does better, even if it didn't achieve statistical significance in this paper. And we've clearly, while it's not the rule, seen children with open funnels get better than form vision. In terms of stability, reattachment is often incomplete. Again, this is the only kind of detachment where success means any reattachment. Residual proliferation is common. Therefore, initially successfully attached retinas can redetach. It varies on the study, and I think it varies depending on how much proliferation is removed. The catch is that as the eye grows, the proliferation per se does not. So if it anchors two different areas of the retina with the eyeball growing larger, the proliferation is stronger than the retina, and the retina can rip, rendering stretch breaks, at which time one typically sees vitreous hemorrhage and neovascularization. To summarize then, surgery does provide a better chance for vision in stage 4B and stage 5 than the untreated natural history, occasionally with a very pleasant surprise of dramatic improvement. Younger children with open configurations fare best. It is typically 2 years or more until maximal acuity is attained, and initially successfully reattached retinas can detach, so these children need to be monitored on an ongoing basis. Sengul, thank you again for the opportunity to participate.
Thank you, Tony. It was a great review of the surgical approach. And I think the next one is me. So I will try to share my screen. And I will talk about the scat reseal phase of ROP in adolescent and adult cases. So actually the scat reseal or regressed ROP has been described by ICROP group in 1987, and they have described some peripheral and posterior changes. And in the peripheral retina, persistent avascular peripheral retina, abnormal branching retinal vessels, pigmentary changes, vitreoretinal interface changes, peripheral retinal folds, lattice-like degenerations, and tractional or rhegmatogenous retinal detachment has been grouped in these cases. And also in posterior retina, we can see vascular tortuosity or straightening of the blood vessels in the temporal arcade as here, and decrease in the angle of insertion in major temporal arcade, and some distortion and ectopia of macula usually to the temporal area, and dragging of retina over optic disc are very typical. And we also know that high myopia and astigmatism and amblyopia are very common together with glaucoma and cataract. And we can see also vitreous hemorrhages in these eyes from late reactivation of fibrovascular proliferation and exudation after having stable regressed ROP, especially in the era of anti-VEGF treatments. And I would like to share some cases with you. This was a 20-year-old young gentleman, and he was followed in USA from birth, and he had previous patching treatments for amblyopia and strabismus, and he had laser photocoagulation for lattice degeneration in both eyes during adolescence, and he came for a control visit without any symptoms, and the visions were quite nice, 20/25 in both eyes. I don't have the color pictures, but you can understand very well that the decreased angle in the temporal arcades and a little bit ectopic macular area in the temporal side, and straightening of the vessels, which are very typical for adult ROP. And the fovea was almost normal in the left eye, but shallow, typical shallow fovea in the right eye. But when we look at the fluorescein angiography, you can easily see that there were quite a lot of area of peripheral avascular retina, and also together with it, there were some leaking vascular structures in the rich area, and these were previously lasered lattice degeneration areas. And in the left eye, almost similar, maybe a little bit less vascular activity, and again, peripheral avascular area. And there were many vitreoretinal interface problems and vitreous membranes in the periphery, as you see here. And I couldn't leave it like this, so I did laser to both eyes. And since then, no problem. It's been like 6 years. Although he was asymptomatic, I couldn't leave so much leaking vessels and peripheral avascular area alone. So that's why we just discussed before. And we are very familiar with the scenario of rhegmatogenous retinal detachment in sagittis and also some tractional retinal detachment during follow-up. We know that some adult ROP cases with rhegmatogenous retinal detachments may be misdiagnosed as Stickler-like disease if they don't ask about prematurity. So please ask about prematurity in adolescent or young rhegmatogenous retinal detachment associated with high myopia and shallow fovea in OCT. And we know that when we have a rhegmatogenous retinal detachment in adult ROP, they are usually more complex detachments, more likely to require multiple procedures, and we have lower visual and anatomical outcomes. And 2/3 of the patients who underwent vitrectomy had poor postoperative visual acuity, as in the literature. And again, I would like to share a case with you. This was an 11-year-old boy with sudden loss of vision in the left eye. Again, prematurity story, no treatment for ROP before, and his ROP was discovered at 4 years old age for application for strabismus, and he was followed as scatricil ROP in another center since then. And vision was 0.05 in the right eye and 0.3 in the left eye previously in the reports, but he was referred for the retinal detachment in the left eye. This was the lower vision eye, the right eye, and you can see the macular fold, which is probably from the birth, from the early ROP. But the left eye, which was previously better seeing eye, now can see only counting finger vision, and retina was totally attached in the temporal area. Nasal area was still attached, but you can see PVR-like structure. Actually, this is a recent detachment. This is not a PVR, but this is because of the already present membranes because of the scatricil ROP. So what I did is I did encircling band, and I had to do vitrectomy because of those membranes in the macular area. And as you can see here, those membranes were very tightly attached to the retina, and I had to do bimanual surgery. I don't know if my video flows fluently, but you can see that when you just try to pull the membrane, it will cause a retinal break. So I'm trying to make a counter force with the second hand to peel those membranes. And it's really difficult to peel the posterior hyaloid in these eyes sometimes. Maybe plasminogen may be very useful for this, but I don't have it in my hands. So I had to do it with bimanual techniques, try to peel it as much as possible, especially in the area of retinal break, which was in the superotemporal quadrant, as you see here. They are usually in the peripheral retina, and they are usually in the avascular area. And with time, they become, with the contraction of the posterior hyaloid, they cause retinal breaks, like in this case. That's why I don't want to leave these eyes without laser when I see avascular retina in sagittis. And after doing all the laser and giving the silicone oil, although this was a very recent case, This was the fellow eye had some pigmentary changes and lattice-like degenerations in the periphery, so I did laser. I don't know if vitrectomy helps in this eye or not because of the amblyopia issues, because the other eye was the better eye from the beginning. This was post-op first day, and this is the first post-op week, and this was the first post-op month. It's still there, retina is still attached, but I'm not sure about the future, you know, in these eyes, since I couldn't peel the posterior hyaloid efficiently, it may cause contraction in future. So we have to be careful about that. And this is another case, a 13-year-old boy with strabismus in the right eye, and we have discovered a chronic inferior retinal detachment in the right eye, in the inferior part. The left eye also had some scatter-seal changes, but vision was quite good in the left eye as compared to the right eye. As you can see, the shallow detachment in the macular area, which was much higher in the inferior part. And what I did is just inserting band and cryo, because I don't want to touch to vitreous if possible. If I don't see too much membrane, as in the previous case, I try to do it externally as if possible. And it did very well. So what about the scatter-seal cases? I mean, with tractional retinal detachment. So should we operate them or not to operate them? We should judge this because we should ask some questions to ourselves. Is the retina detached since neonatal period? So is amblyopia an issue? Will it be possible to get a useful vision if anatomical success is achieved? And there's also risk of losing the present vision. Is no surgery better? So we should weigh these pluses and negatives. And this was such a case. This was 6-year-old previously prematurely born baby, not baby, but now he's a boy, and vision was 0.1, and I operated him in 2015. As you can see here, there were peripheral superior traction and it was anteroposterior traction. So I felt that it could be relieved easily without causing too much trouble to the retina. And when I see this, if it is, you know, anteroposterior traction, not a tangential traction, you don't have to cause too much traction in the retina, and you can preserve the retinal integrity, and you can have a good vision, and at least you can preserve the vision. As you see here, macula was ectopic to the superior and temporal part. And this was the better eye. And this is post-op 4 years. When he was 10 years old, vision improved to 0.3 from 0.1. So he was happy. Actually, my main aim was to preserve the vision for future, but still vision was much better. This is another case. This was a very surprising case for me because he was 6.5 years old boy, and vision was 0.1 and 0.15 in both eyes. And he didn't have any treatment for ROP before, and he came for strabismus, and we discovered this. And when we asked about the prematurity, we learned this. And as you see here, both of the retina, in both eyes, retina were direct towards the infero-nasal area with the anteroposterior traction, and the anterior end of the membrane was at the back of the lens. And I again judged it, and I decided to do the surgery. And since the macular area is detached, I thought that this was not detached like this in previous years probably. As Tony told before, when the eye grows, those fibrotic membranes doesn't grow, and it will cause more traction in the posterior retina, and probably the macular area is detached more recently. That's why I thought that when I peel and when I release those tractions, it may cause increase in vision. And without touching to the lens, we can leave a little part of the membrane at the back of the lens. It may contract and it doesn't cause any problem usually. And we try to peel membrane as much as possible, but we can leave the ones if you feel risky for the retina. So this was the end of the surgery, and this is after 3 years of follow-up. Vision improved to 0.7 from 0.1. Although the macula was ectopic, but quite nicely attached, and vision improved nicely. And in the fellow eye, vision improved, but not that much. Probably this was the worst eye from the beginning, and with amblyopia issues, it improved just like this much. So in such cases, it may be useful to do surgery. This was another interesting case, which was both of eyes look stage 5 and one eye with corneal opacification. So I didn't think anything about that. But for the right eye, he had hand motions, and the family insisted on having surgery. He was 4 years old, and it was like this, as they told me, like this from the beginning. And you can see the posterior ultrasonography. You don't see the retina, but you have some tractions in the posterior pole, not a closed funnel, but some tractions. So these are the cases that we discuss within each other. So what I did, I just wanted to give a chance to this eye. I did, of course, a lensectomy. I couldn't plan any lens-sparing surgery for such a case. And as you see here, when you peel the membranes, retina is going backwards again more and more. Since this was the better eye, I have to be very careful because I don't want to lose the hand motions vision. And when you go backwards more and more, retina is going back. Even the vascular structures are detached from the retina, but still you have some attached retinal areas. So what is the result? So the anterior segment was like this. This is the end of the surgery, and this is 3 years after the surgery. And it was very interesting for me that he had very good ambulatory vision after the surgery. The optic nerve was probably somewhere here. And so vitreoretinal surgery may lead some good anatomical and functional results in some of the cicatricial cases, and we have published a paper on such cases. This is another interesting case because cicatricial ROP cases also have cataract, earlier cataracts, and this was a retinal detachment, a rhegmatogenous retinal detachment in the right eye, and left eye also had tractional retinal detachment in the periphery, but I had to do surgery to the right eye, and I had to do vitrectomy together with cataract surgery. Retina was attached. Lens was quite nicely there, but I have put the intraocular lens, but now I think that I shouldn't put the intraocular lens in, although she was already 11 years old. But with time, the fibrotic tissue at the back of at the temporal side of the lens capsule, although I have opened the central part, it contracted within time, and it caused some dislocation of the lens. So she has cataract in the fellow eye. I couldn't see the retina as you see here, so I had to do the surgery again to the left eye. Probably I will have to extract the intraocular lenses. So even the cataract surgeries are associated with a high rate of retinal complications in these eyes, and we should follow them regularly also for retinal complications. So my take-home messages are premature babies need lifelong follow-up, and they have high myopia, lattice degeneration, vitreoretinal interface diseases, rhegmatogenous or tractional retinal detachments, which are usually more complex, and we can have late reactivations of the disease, and even cataract surgery may lead some important complications. I'd like to thank to my co-workers in Gazi University, Baran, our host today, and also Dr. Tuba Atalay, who is our pediatric ophthalmologist, and the next talk will be hers. Thank you. I hope I did. And I will leave the microphone to Dr. Tuba Atalay.
Hi everyone. So thank you for the introduction. It was a very nice talk, Dr. Özdek.
Thank you.
To be here among this esteemed faculty. Thank you for giving the opportunity. So I will share my screen now. I think you are able to see, right? Can you hear and see me? Okay.
We can hear and see very well.
I will talk about management of long-term visual complications of ROP, which causes low vision. And I will start with some case reports, case presentations, which represent different stages of ROP and treated with different treatment modalities and their visual outcomes. My first patient is a 6-year-old boy. He had no treatment for ROP, but he was spontaneously regressed and came us with a scatricial ROP on both eyes. And on color from these photos, we are seeing straightening of the vessels and macular dragging on both eyes, which is worse on the left eye. His refraction is -5 on the right eye and -250, 350 astigmatism on the left eye. His vision is really good on the right eye, it's full, but on the left eye it is 0.2, and he has an esotropy on the left eye. My next patient is a 7-year-old girl. Again, she did not have any treatment for her ROP. It was a spontaneously regressed ROP on both eyes. On the again, colors from the photos shows macular dragging, which is worse on the left eye. On the right eye, her astigmatism is quite low, but on the left eye, she has a moderate to high myopia and astigmatism. And on her right eye, her vision is good. On the left eye, it's 0.4. And she has a pseudo exotropia because of the macular dragging on the left eye. Next patient is a 5-year-old girl, had laser treatment on both eyes for ROP. And on color from these photos, we see that macula is in the place, there is no dragging. There are laser scars on the periphery. On refraction, on both eyes, she has a moderate to high myopia and astigmatism. With her glasses, her vision is really good on both eyes, and she's orthophoric. This is an 8-year-old girl. On the right eye, she had an pars-plana vitrectomy and lancectomy because of stage 4B ROP. On the left eye, she had only laser treatment. In this patient, it's a special case because she's aphakic on the right eye and she has a high hyperopia. And on the left eye, she has a high myopia and astigmatism. So she has also high anisometropia. And on color from these photos, we are seeing that anatomically, after surgery, she is in good shape, but on the visual acuity on the right eye is counting fingers from 1 meter. On the left eye, she has a good vision, and she is presenting with exotropia. This is an 11-month-old boy. Had pars-plana vitrectomy and laser treatment on both eyes with stage 4B ROP. On both eyes, he has high myopia and astigmatism. He was able to fix and follow with eccentric fixation, but again, because of the dragging also, he has a high exotropia. This is a very cute 1-year-old boy, one of our patients. He had bilateral intravitreal anti-VEGF injections for his ROPs on the both eyes. The color from these photos shows really nice anatomical outcome. On fluorescein angiography images, there is a little avascular retina in the far periphery. His refraction is really low, -1 astigmatism on both eyes. He was able to fix and follow really good on both eyes, and he was orthophoric. And this is my last case. Actually, this is one of Dr. Zuhal Tunay's patients. I would like to thank her for the photos. A 3-month-old boy. He had a spontaneously regressed ROP. In 3 months old follow-up visit, his vision was only light perception on both eyes, and he was not fixing or following. And on color fundus photo, there is a setting sun eye sign, and which is typical for hydrocephalus. This patient had a grade 4 intracranial hemorrhage, hydrocephalus, and periventricular locomalacia. Fundus photos looks really good. His low vision insufficiently explained by his ocular findings, and this is a typical scenario for cortical or cerebral visual impairment. He was a lucky patient because he was diagnosed early and started treatment and visual rehabilitation early, and now he is seeing really good. So what is the visual outcome of ROP then? Those are 2010 numbers from a paper. 13 million babies born preterm have survived. An estimated 180,000 preterm babies developed any stage of ROP. 50,000 of them progressed to potentially vision impairing disease. 20,000 of them became blind or severely visually impaired from ROP. Following preterm birth, there are 3 key factors that influence visual outcome. Preterm birth itself, presence of ROP or neurological comorbidities. We can see them solely or in combination. And in those visually impaired patients, only 1 to 25% of cases have visual loss due to unfavorable outcomes in relation to the retina, like detachment or macular dragging or scarring. The main causes of visual loss were refractive errors, amblyopia, strabismus, and perinatal neurological events. The most common visual complications of prematurity are ROP and cerebral visual impairment, and CVI is associated with developmental delay and cerebral palsy. Also, high refractive error, especially myopia, is really common in ROP patients. Anisometropia, strabismus, and amblyopia are common in ROP. And we also are able to see some coexisting pathologies like glaucoma and cataract, retinal changes, nystagmus, and laser-related peripheral visual field effects. Myopia in premature babies can be associated with prematurity without ROP, spontaneous regressed ROP, or treatment for ROP. Chains at the front of the eye are the reason for this myopia. Those babies have steeper cornea, shallower anterior chamber, and thicker lens. In this nice chart from Vijay Lakshmi's paper, we see that the preterm babies who did not develop any ROP are in low risk of myopia. And this myopia is low in degree and develops around the age of 4 to 5 years. Babies who have developed any type of ROP are at higher risk than those who did not. And myopia may be more severe and have an earlier onset in ROP patients. The ROP patients that was treated with laser, who received laser treatment, have the highest risk for high myopia, and that myopia may develop high in a few months of treatment, and their myopia can progress rapidly before it stabilizes. Again, astigmatism is really common in ROP patients, and 25 to 50% of them are more than 2 diopter of astigmatism. The prevalence of refractive errors varies across studies, as shown in this table from Filter's paper, and it is the highest in the extremely low birth weight and following for the severe ROP patients. ET ROP numbers are really high. Anisometropia is really common, 10 to 50% in laser-treated threshold ROP eyes, and with higher degrees of myopia in eyes with more posterior and more severe retinopathy. And detection and treatment early is crucial to avoid amblyopia and strabismus. But we all know that there are new treatment modalities, there are less invasive. Bead ROP study demonstrated improved structural and likely refractive outcomes for infants who received intravitreal bevacizumab when compared to laser therapy. And some more recent studies reported favorable visual acuities after treatment with anti-VEGF agents and less myopia and less astigmatism than laser treatment. Those children with ROP should receive regular and frequent ophthalmologic care. And that care should include cycloplegic retinoscopy and dilated retinal examination in each visit. First visit should start at 6 months of age, and we should repeat those visits every 4 to 6 months. Suggestions for prescribing at different ages are shown in this table, but we should remember that each patient is different and each treatment should be tailored to the individual patient. Strabismus, ROP is significantly correlated with strabismus also. ET-ROP study shows that 42% of laser-treated eyes develop strabismus at 6 years. And prematurity, poor vision, abnormal fixation, amblyopia, and neurodevelopmental abnormalities are strongly correlated with development of strabismus. In ROP patient, esotropia and exotropia seen in equal frequency. In term babies, it is in favor of esotropia. But we should be careful. We should rule out changes in the retina, such as macular degeneration, because it causes pseudostrabismus, and it may lead us to misdiagnosis and wrong surgeries. Treatment of strabismus entails correction of any refractive error and occlusion of the better seeing eye to treat amblyopia. And surgical correction can be also treatment choice, but because of the variability in alignment, conservative management of strabismus is warranted in the first instance. 79% of children remain strabismic even after surgery because of low potential for binocular vision and ocular or visual function abnormalities. Children with neurological impairment have a higher incidence of strabismus and poorer surgical outcomes. Amblyopia is common. 20% develop amblyopia, the ROP-treated eyes, and it happens secondary to anisometropia and or strabismus. We should correct the refractive error, and we should apply occlusion therapy or penalization of the better seeing eye for the treatment. My last topic is cerebral visual impairment. Cerebral visual impairment is really common in developed nations. It is the most frequent cause of pediatric visual impairment, but it is increasing in prevalence also in developing nations also. CVI change in, it happens because of the brain injury in premature infants, which might be mild to moderate episodes of hypoxia and hypoperfusion, and periventricular leukomalacia is the leading cause of CVI in premature babies. CVI ranges in severity from blindness to relatively minor impairments of vision and perception. Its diagnosis is clinical. Diagnostic criteria are reduced visual acuity, a normal ocular examination, and confirmation of damage to the posterior visual pathways. You might see optic atrophy, increased cupping, or a sign in neuroimaging, but this confirmation is not always the case. My take-home points are prematurely born children have an increased risk of various visual abnormalities. especially those with severe and treatment requiring ROP and with severe cerebral sequelae. And we should follow up those children periodically during that crucial period of ocular growth and visual development. When we assess and follow up those children, we should follow those steps. Is the child developing normally? Does the child seem to have normal vision? Is strabismus or nystagmus present? Is there a significant refractive error? Does the retina look normal? Are there any other eye problems? Infants who are visually impaired from retinal sequelae and or neurological deficits should start vision stimulation and rehabilitation therapy early to reduce the developmental delay associated with severe visual loss. And it should be a multidisciplinary care treating those children. Thank you.
Thank you, Tuba. You're doing great job all the time. You know, we do operate, but you make them see. I should say that. Thank you for your great efforts. So this was the end of the last session, but now we can discuss anything you want. So first of all, Tony, it's your, you can start any discussion if you want. We have some questions from attendees also, but we can start first.
I have a comment along the same lines that you just made, and that is that I thought Dr. Adelaide's presentation was great, and people like those of us on the conference, either attendees or speakers who are surgeons, without a partner in pediatric ophthalmology who's truly dedicated to these kids because they are unusually challenging, the work is almost wasted, because our job in many ways is the easy job. To take that child and optimize their visual potential really takes, you know, a dedicated and talented pediatric ophthalmologist who understands how these kids are different. And that's a critical component. You know, we've been fortunate to have that. We don't talk about this very much at meetings, but it is the sine qua non. It is the sine qua non.
Okay, thank you. I completely agree. And there's a question for her. Maybe we can start with that. How do you treat strabismus in these eyes? One of the questions from attendees.
So if those patients have a pseudostrabismus, I think being conservative is better. If that baby has a macular ectopia, ectopic eccentric fixation, and if we operate on them and correct the strabismus, they may have diplopia. So going conservative is better in those cases. Sometimes with low vision, very low vision, parents insist on surgery. For good cosmetic outcome, we may go for surgery, but it is, I mean, not very rare. Those patients are very rare. If those patients have true strabismus, we do surgeries and they become really happy with the outcome.
Okay, thank you. And there's a question from the attendees again. What do you do if you have a posterior pole break in ROP surgery? We can start with Tony, Nina, sure. Amy, all.
I think we all have we all have opinions on this, but I think whenever you have a break in an ROP surgery, the challenge is you need to make the retina relaxed enough that you can put it onto the pigment epithelium so that you can perform retinopexy. So either that means taking away more proliferation, maybe more than you originally intended, to get the retina relaxed enough to lie flat, or support the eye wall. And I've done radial buckles that go all the way back to the nerve if I have to put a posterior break on the pigment epithelium so you can do retinopexy. If you can't do that, you really can't fix the eye, and there's no merit really to filling the eye with silicone oil, in my opinion. So that's my thought on that. I'd be curious to hear what others have to say.
Okay.
So that's like an awful feeling when that happens. But I switch gears and I start to use a lot of the tools I have in adult retinal surgery. So, you know, when I do pediatric retina, I'm always trying I'm trying to gently, Tony did such a great job describing the vectors, trying to relieve the vectors and allowing, and Shengo, you did as well, and allowing the retina to settle back. When I get a break, I start thinking like I would with removing as much vitreous traction, just exactly what Tony said, and really, reattaching the retina, laser and silicone oil, and hoping for some.
I have to say that I feel like Emmy right there. I get very quiet, and I know that my OR time will get exponentially longer in that case, because I can't believe I did it, and I can't believe that there's a chance that I can't fix it. So yeah, it's a terrible feeling.
It is, and then you have to like say, okay, that's not helpful. I mean, that's what I have to do for myself. Okay, this is awful. What did I do? That's not helpful. Just switch gears.
Separate the emotion from the case, which, yes.
Well, maybe one thing we should say out loud. I don't think any of us has said, well, just do a 360-degree retinotomy. I think that it's tempting, because you're right. Instantly, that case becomes a 3 to 4 hour case. But something that is really not effectively work at my hands, and I've tried it, and I've been doing this for many years, is saying, well, okay, the only way I can get the retina to relax is by just cutting away all the anterior proliferation and having a 360 retinotomy and having it lie flat. In decades of doing this, I've not seen that work.
I agree. And sometimes when you say, okay, let me do that, and you start and you see it recoiling back, and you're like, oh my God, it's never going to work. It's never going to work. There's going to be oil under the retina, and the case is done. It's awful. It's an awful feeling.
Leila?
Yeah, I think everybody has a doom feeling in your gut, and you just kind of want to pause and take a breather and then go back in and address it. But I think all of us take extensive efforts not to get to the tear. So, I think positioning, just taking time. And I think with ROP cases, I definitely always schedule when there's no other conflict. Like I'm just like, I know that day, while they come emergency, I just want to clear my day and not think about that I'm rushing through this case to get to, I don't know, an appointment that was scheduled in the afternoon. So you just want to kind of dedicate a block of time and feel like you're there for that case. So.
Thank you. Susanna, you want to comment? Unmute, please. Unmute yourself. We can't hear you.
Well,
okay.
It's the same. When I have to do a vitrectomy for ROP, I take all my time and all my efforts and do the least I can do to do the best, So try, you try to take everything, like in adults, you go and take, but in children, you must just cut enough to get the best results. And if really if you make a hole in the posterior pole, well, it's like the ground disappears, and we can try to relieve everything, but you have an hyaloid and inner limiting intern membrane that it's always there making traction on the hole. So it's
okay. I have some ideas about this, and I would like to hear your comments on that. If I have a peripheral break in a silent area, or it can even be in the posterior pole, but if it is in a silent area, if you can peel the posterior hyaloid or the fibrotic tissue in that area, it usually goes well. But if it is in the most proliferated area, in the rich area or contracted area, of course, I'm not talking about stage 5 cases, but for stage 4 cases, if the break is in the silent area, it goes well with the buccal or all those things. And if it is in the proliferated part or in the macular area, as the question asked, did you think about trying T-cell or amniotic membrane to seal that area? Because I have tried T-cell in one of my cases. It was not an ROP case, but that was something else. I don't remember, maybe fever, something like that. I had a retinal break and I put T-cell I just wanted to try, because otherwise I know that I will lose the eye. Although this cell is not used for intraocular use, but I just tried and it went very well. So I don't have, you know, a serious, but maybe amniotic membrane, a piece of amniotic membrane may also seal that posterior break, like in recurrent macular hole cases. What do you feel about that? I just want to hear your comments.
Well, it may be a good idea, but amniotic membrane in the posterior segment, it's preserved for a long time, but perhaps it will disappear. I don't know. It will.
I didn't try it yet.
Can be there, but I've got no experience, so it's difficult for me to. But it's very anguish to know that you make a hole and it cannot fix it. So it's every day you think about a solution for that problem.
Okay, one more question. Do you have any criteria for a stage 5 eye as inoperable? Inoperability criteria for stage 5 eyes. Do you operate all stage 5 eyes? Please, Maria.
I do stage 5 eyes almost every day. We have too many babies with a stage 5. And no, we do surgery to any of them, because sometimes it's the only chance of preserving some light before the eye goes to phthisis. So we try in every of them. And you may be avoiding a neovascular glaucoma, or you may be avoiding a blind, painful eye. So we do try in all of them.
Okay.
I will tell you that I get them from outside the United States, and I will try, but I will not do the ones where the cornea is white. I know that, Tony, you guys used to do PKs at the time that you fixed stage 5, but I won't do that. So if the cornea is gone, I won't do it.
And then in addition, like for eyes that, it depends on what the status of the other eye is as well. Kind of guides the treatment and how aggressive, but yeah.
So when I worked with Hiroshi, he would have sort of a cutoff at 2 years if the detachment had been going on for 2 years.
Okay, so for me, actually, I try to operate stage 5 eyes, but if there's no corneal opacification, that's my inoperability criteria. Because I can't, if you do the corneal grafting, they usually reject. So I don't do that. And if you try to do the dissection through the cornea, which is not that bad, you can't peel the membranes efficiently, and it doesn't cause any better vision. So I don't operate those eyes. And if it is, if it has been too long, and if the baby, the fellow eye is a seeing eye, and if the family is not motivated for that, I don't operate those eyes. But if the family is motivated, at least for the anatomical preservation of the eye to prevent future corneal opacification and future phthisis bulb development, I can suggest surgery for stage 5 eyes, but if they're not motivated and if the fellow eye is seeing, I don't operate. So I think these are my, yes.
Well, I usually also, I usually just do surgery in stage 5, bilateral stage 5. If you have a good eye and the other one with stage 5, I don't encourage the parents to make the surgery.
Mm-hmm.
So
speaking of the issue of corneal opacification, Nina, I agree with you. Perhaps Mike did the PK procedure on the completely opacified cornea, and I certainly don't do that. However, I will say there are a number of stage 5 eyes that have a localized corneal opacification where they have capsular endothelial touch. And so for those eyes, I will do a lensectomy, capsulectomy, and then return in 3 months. And many times the cornea will clear, and then you can enter the funnel, because to Sengul's point, if you can't see you do the dissection, and it's the least forgiving dissection you do, right? Make a break, lose the eye is the adage. Then you need to have a good view. So with a localized opacification, as I mentioned, lensectomy, capsulectomy usually requires a little anterior segment reconstruction to sort of desynuclealize the iris, etc. So if you are fortunate, then on the second procedure, you'll be able to open the funnel. At a minimum, by taking out the lens, the eye is more likely to have a normal growth, less likely to have angle closure glaucoma, and so on and so forth. So it kind of resonates with my comments at the beginning of the stage 4-5, and that is the surgical goals need to be sort of proportional to the degree of pathology. And but for a totally white cornea, I wouldn't do that eye. For an eye that has a totally closed funnel that's over a year old, you're not going to open the funnel. Number one, you're not going to get any vision. Number two, most likely. So the temptation to operate on all comers is higher for a younger child, less likely for no view, old kid, completely closed funnel.
Yeah, I agree. And I will also say that you can do an open sky vitrectomy. And when we would do that, it wouldn't be the totally opacified corneas. It would just be partial. But you have to you have to be cognizant. Sometimes you have to drain some retinal fluid first, because you can get the back pressure, which then pushes out and causes a break. So, you can take the cornea off, put it back on, and sometimes those corneas will clear.
Okay, and there's one more question about the enzymatic vitreolysis before surgery. Tony, this is for you. Any experience with?
That's a great question. The place right now, so now it's commercially available. And for many times we used it for, not for primary surgeries virtually ever in the infants. It was always for a secondary surgery where the funnel had started to open, but there were limitations to how open it was because of residual proliferation. Interestingly, that's really not where we use it anymore. We don't use it for that. The most common use for enzyme in our hands in ROP is for posterior hyaloidal contraction and opacification. So adult cases of the sort that you described, where you said you don't have it available, that's the kind of case. So we're seeing, and I'll keep this brief because it's really kind of another lecture, but hyaloidal contraction occurs either in infancy or in adulthood. And you can do any case without the enzyme. The enzyme, just like a lot of the other adjuncts that we have, makes the surgery easier and faster. Some adults will have diffuse hyaloidal contraction and gradually lose vision. Adult ROPs, particularly that weren't treated. So for whenever the hyaloid is very dense, and so that spills over to some fever cases, because the hyaloid is very important in a lot of fever cases as an underappreciated component. So to address diffuse hyaloidal attachment and opacification is really the main indication in my hands.
Thank you, Tony. And there is another question from my neonatologist friend, Canan Türk Yılmaz. He's asking about the mesenchymal stem cells treatment for ROP. Did you hear anything about that, or? I didn't hear anything about that.
I have no experience in that regard.
Okay. And at what percentage do you see cataract development in babies with anti-VEGF or laser treatment for ROP? Another question. Anybody to answer?
Very rare.
Yes, I never had one.
If you don't touch the lens during injection, it's really, really very rare.
Yeah, I think you must be concerned there was a complication, so if there was a cataract. So.
Yeah. I think we have completed most of the questions, and I would like to thank you all. It was really great and very nice discussion. I enjoyed a lot, and thank you for staying with us together, for the attendees together with us till the end of this 4.5 hour course. And I'd like to thank to Gazi University Eye Foundation and EVRS, of course, and to my great faculty, to Baran, our host, my fellow, and to all the attendees. Thank you for joining us, and I really enjoyed your presence here. Thank you for giving your time till this late night. Thank you.
Thank you, Sengul.
Organizing.
Hope to see you again in person in better, healthy days. Nina, bye.
Hopefully.
Hopefully.
Bye.
Stay safe. Bye-bye.
You too all. Thank you.